I was so compressed, I was so narrow, I could tolerate all 9 millimeters of my expansion, and generally speaking, the reception to the facial changes I've experienced has been positive.
So this is true cheekbone enhancement.
Yeah, that's correct.
This is not a bony overlay or a peak implant.
No.
This is,
That's real.
geez, man, that's way up in your eye. Wow. If you've been on the fence about doing an expander, this podcast is for you, because in it, we discuss Dr. Newaz and Dr. Jaffari's experience with almost 100 FME cases. The FME is the Facegenics Midfacial Expander. It's the latest and greatest technology when it comes to devices that split the mid-palatal suture, expand the entire midface, tremendously improve nasal breathing, augment midfacial aesthetics, provide tongue space to allow for better tongue posture, relieving the pharyngeal airway. All of these things that we seek out of expanders, the FME aims to do all of them in spades and better than anything else. But does it do better than everything else? Does it do better than custom MARPE? That's what I asked Dr. Newaz in this podcast, and him and Jaffari tell us about their experience getting their hands very dirty in the trenches, treating patients across the eastern seaboard and actually across the world with the Facegenics Midfacial Expander. We're going to take a look at the asymmetry question. We're going to take a look at the posterior versus anterior expansion question. We're going to take a look at the FMA, the Facegenics protraction device that integrates with the FME. We're actually going to put eyes on that in this podcast, showing video and photo footage of what the FMA looks like in action. And man, it's crazy. This thing is wild. It is highly engineered. It's very robust, very involved, probably very expensive. Price is another thing I talked to Dr. Newaz and Dr. Jaffari about. Why is the FME treatment priced differently than the custom MARPE? And you'll be curious to hear their answer as well. Now, if you're someone who's interested in getting treated with the FME, of course, you can talk to Drs. Newaz and Jaffari about that. They have an order of magnitude more experience with the FME than any other provider. Almost 100 cases where the next closest provider has somewhere in the range of 10. So if this is the device you're interested in, these are the guys for you at the time of this recording in September 2025. And if you want to speak to Drs. Newaz and Jaffari one-on-one, you can do so inside of The Joint, which is the JawHacks membership coaching space. That's where I speak to you one-on-one about your own case, as well as bring in the people that I podcast with, such as Drs. Newaz and Jaffari, to engage in group video chats with the members. And if you want to talk to these guys directly instead of just watching them from a distance as a third party in a podcast, you can do so inside of The Joint sometime in the next month. They've already agreed to come in. We just need to schedule it. Link in the description if that's something you're interested in. One last note before we begin. I want to thank Shuikai for providing the GIFs that Drs. Newaz and Jaffari use in the podcast to illustrate Dr. Newaz's own treatment with the FME. He's actually in treatment as we speak at the time of this recording. He's had a between 8 to 9 millimeter FME expansion himself. And instead of speculating about what all occurred with that expansion, we can put eyes on it thanks to Shuikai's masterfully done, perfectly done superimpositions of Dr. Newaz's before and after cone beam CTs. So thank you to Shuikai. The podcast couldn't have happened without you. So Drs. Newaz and Jaffari, 98 FME cases down, many more to go. What's the deal? Is this thing legit? Is this the ultimate in expansion? Has it solved the asymmetry problem, the failure to split an adult male problem? What are your takeaways after 98, almost 100 FME cases under your belts?
So far, the results are pretty solid. We've had a lot of success with our patients and some failures, but that comes with the territory. And so we're really excited to kind of go over that and show you some images today.
What is a success? What does that mean? And then what is a failure? Because obviously, is it a success to just say that a patient split, or does it have to be a good, clean, symmetric split that demonstrates a real positive, airway change? Or what are we calling success? It's actually a controversial point in the MARPE conversation.
Fantastic question. For me, it's all, when we talk to our patients, we speak to them about absolute and relative failures. And I think the relative failure is a gray box that I think is, I think that what makes something a relative failure is based on the individualized objectives that you may have for a patient, and also the context of their global treatment, their global treatment plan.
Sure.
Right? The global treatment plan may include surgery. It may include a possible surgery, reevaluate to do surgery. It might include other interventions from other professionals. And so the acceptance of certain deviations from a very perfect outcome may be more or less acceptable depending on what that patient's overall sort of outlook for treatment is. And also seeing how that particular individual responds to the expansion having gone a certain way, right? And with everything in medicine, there's a subjective and an objective way to measure things. And I think we certainly weigh both pretty heavily. So we look at what's objectively happening, but we certainly take into account some of the subjective reports.
Make it concrete for me. Give me tether what you're saying. I know you're talking about individualized sort of interpretation of cases, and you're not giving me the kind of, quick fix answer that I'm kind of fishing for of, this is a successful case is one that's parallel, one that's perfectly, expanded in magnitude, one that is posterior, not anterior, all of these cliches that we have tossed around. You're really giving me more of a mature kind of honest take of what is a successful case, which is individualized to the nuanced. What did they come here complaining about? What's their pain point? What's the totality of their treatment going to look like? And how does this one component of treatment fit in? But that's kind of abstract for, I think, a lot of the viewers. Tether it for me in reality.
Well, I'll say what's perhaps not abstract about it is that did we meet the patient's objectives? And did they have a quality of life improvement in the process of doing it? And do they have maybe an easier or harder time getting to an endpoint that would be in service of the patient's goals and wellness?
Right.
For me, that's actually a tangible conversation. That's not a vague conversation. So what I mean by that in particular is that you could have 10 individuals who have the exact same expansion. Let's say that exact same expansion is, a slightly imperfect type of expansion, right? Let's define perfect expansion as, let's say an expansion is totally vertically neutral. There's totally neutral movement of the septum and other midline aligning structures. Let's say that there is a slight but acceptable deviation, right and left in terms of symmetry problems, right? Because we have very pronounced symmetry problems. We have subtle symmetry problems. Let's say we have 10 that are in that mild asymmetry category, right? For some, that may come in a context of, a person's facial features and structures, them being more sensitive to those changes because their face cannot tolerate that type of asymmetry in that direction. Maybe it should have been in the other direction, or maybe it shouldn't have happened at all. And others, maybe it actually is in service of, actually adding symmetry to the face. If you look at, which we'll look at later, if you look at my nasal bone, for example, right? My nasal bone, tethers to the frontal bone in the center, and then actually slightly comes, almost like pivots from that central point down to the right, just a little bit. In my case, because my nasal bone was part of a nasal bridge that deflected downward to the left, it actually helped my nasal, my nose symmetry externally to have an asymmetric movement of the nasal bone.
And to be clear, we're talking about your FME
My
case right now.
FME.
And can you just flash that for the camera? Can you just lean back and show your palate? So that is an FME that's fully expanded in your mouth right now. And it's a very impressive expansion. I mean, it's massive. It's symmetric to the eye. I mean, I'm seeing you in person. We've been hanging out for a day. I don't notice any canting or any visual asymmetry in that expansion.
Mm-hmm.
And we're going to look at that in more detail. But you're talking about how in your case the FME actually even reversed a kind of pre-existing asymmetry.
I would say it mitigated. I wouldn't necessarily say reversed, but yeah, I would say that what ended up happening was a more straight nasal bridge, right? Even though the movement of the nasal bone to create that more straight look was asymmetric.
Was that intentional or was that?
No, it was totally unintentional. And I think it speaks to the fact that perhaps there's, maybe some movement in the cranial bones that may just have, let's say cranial bones distant from the rigid anchors of the device being used to cause change, right? If you have other structures, remote structures moving, maybe they tend to move to a position of some equilibrium or homeostasis. When certain physical changes happen in the subject structure, direct structure, then you could have remote things move in such a way that, perhaps, the way that the body's connective tissues and musculatures sort of tether. And, a lot of us with midfacial constriction have kind of like this feeling of being buckled, right? That things are tense, things are squeezed, things perhaps have been squeezed either developmentally or iatrogenically, right? Iatrogenically meaning maybe we've had prior retractive treatments that have kind of moved and twisted things.
Which you have had.
Which I have had.
You're a premolar extraction case like me.
Correct. So maybe when disarticulation occurs, then the resultant movement of some of these remote or distant bones maybe follows a pattern of, untethering or releasing tension in the skull at some of those interfaces between different bony components in the midface.
Yeah, I think that's a bold claim, right? Are you seeing that in cases beyond yours? Because that...
Well, I don't mean to state it as a claim.
Okay.
I just mean to state it as an observation that, and perhaps a hypothesis, and one that I don't claim to understand yet. I sure hope I'll be the first one to understand it.
But that's how it played out in your case.
Correct.
And I want to take a look at your case. I want to get to some visuals immediately.
Yeah.
And tether our conversation in data and in visuals. But first, just elevator pitch version. Out of 98, how many failure to splits have you had?
I would say absolute failures were creeping up on 3.
With midline piezo cut?
Yes.
Failure to expand? Even
Correct.
FME?
Correct.
8, 10 TADs?
Yep.
Midline piezo cut?
Correct.
No expansion?
Correct.
3 out of 98?
Yes. And then we have, another handful, I would call it maybe 4 to 6 patients in the relative failure group.
And what does that mean? That the dimensional stability of the appliance failed somewhere midway through expansion?
I would say that the device maybe stops out somewhere.
What does that mean?
Meaning that too much tension has been built up in the device such that you can no longer activate it. When you've maybe got an initial split, you certainly have some minimal measurable change in the midface or the maxilla or the intermolar width or the nasal floor or whatever have you. You have some measurable change, but you didn't get the intended amount or runway to be able to continue that expansion. Perhaps you get an initial split, but perhaps because of, again, remote resistance or device characteristics, you may have a stalling with your expansion. Sometimes we're able to kind of zigzag our way out of it. What I mean by that is that there are ways that you can reinforce your corticotomy. Later on, you can pop the top off of the FME and you can cut under the device. We've contemplated, but not yet done, for some patients, possibly having to release, the anterior nasal spine area. Something that we absolutely hate doing and generally find to be unnecessary, although perhaps when we start using devices that do rely on the device to split the palate a little bit more, just in that pure, kind of fashion, perhaps there's too much resistance in the anterior for that device to overcome if the mass of bone at the palate is very tall. And we've also seen that maybe correlate some bit with somebody's existing vertical dimension of the face. A longer distended midface, mechanically speaking, may be a little bit harder to split. And that's, I think, maybe a common feature of some of the cases that we're having these troubles with. One of them doesn't quite fit that, but one of the relative failures, doesn't, very much has the opposite problem. So we have to kind of figure out what's going on. I think it may just be just overall resistance, age, demographics, all that kind of stuff. But other than that, we've seen that to be a factor.
What does a patient like that look like? Can you just explain it in layman's terms?
They have a longer maxilla, so maybe they have a gummy smile type of appearance.
High vaulted palate, gummy smile, kind of classic adenoid face, rolled down and back. Yeah.
And we've had other patients that stopped treatment early, right? They didn't like the aesthetics of the split and the diastema. Another patient, after splitting, couldn't handle the tension that his sutures in his face were feeling. And so that caused pain, and so decided to cut treatment short.
And are those of the
anomaly?
Those are of the other handful besides the 3 outright failures. Those are kind of, or would you not even, because that's
I wouldn't necessarily. For me, at least, I haven't. Maybe those 2 patients in particular you just mentioned are not sort of in my repository of those 4 to 6 relative failures. Although they may as well be, because that was more elective termination.
They didn't get what they wanted out.
Well, those are really interesting examples that you bring up, though, because I think, when you talk to an outsider who's not of the jaw hacking world and you explain to them what these skeletal expanders do, the first thing they say is, geez, doesn't that hurt? And then it's like, oh, yeah, this is really a kind of extreme thing that we're doing here. And sometimes it does lead to, it feels exactly the way you think it would feel. I felt that with my MSE type 2 back in the day.
Now, everybody's different too, though.
Everyone has a different level of sensitivity.
The sensitivity, the way their bodies, like equilibrium. Some people have, asymmetries throughout their body, and then when you're expanding, kind of exacerbates that, right? And then obviously for some patients, aesthetics are very important too. And sometimes even while they're in the diastema phase, may not be thrilled. And so like that one patient literally did not want the aesthetics of a diastema.
It was the diastema that kind of freaked him out, not the midfacial changes.
And he still got better breathing too.
And he still wanted it reversed. But didn't he realize that the diastema was temporary?
Very much so. We even offer things for those who want to mitigate their diastema, maybe starting orthodontics earlier, or even doing temporary bonding, which is something that Dr. Jaffari can very skillfully do. Being a restorative cosmetic dentist, he can pretty much, he can patch up a lot of stuff. Like if I stopped orthodontics right now, he could probably somehow, or didn't, I haven't started orthodontics yet after my expansion. But if I just didn't do orthodontics, let's just say just moving teeth was not an option. In my case, he could somehow make this mess look pretty good.
Right. A very under-discussed topic
absolutely
in the jaw hacking space, I think, is combining restorative work with expansion.
Especially as it pertains to the prospect of maybe minimizing some of your orthodontic treatment risks.
Oh, and also, both indiscrepancies contribute to all the arch issues too.
Yeah.
One more time with that point.
So the Bolton discrepancy, the sizing of the teeth may keep the arch narrow as well, contribute to that narrowness.
Right. Too much teeth for not enough arch?
Too little teeth,
Or too big of an arch?
possibly.
Right. So make the teeth a
Or
little bit
the-
bigger after expansion?
Or the teeth are making the arch smaller too. So if all the teeth are touching, for example, some people still have an edge-to-edge bite. The teeth themselves could be small, causing the edge-to-edge bite.
Right.
And so, some of the things that we do is we'll keep spaces on purpose and then do restorative dentistry instead of closing up all the spaces.
Closing up spaces sucks anyway. It takes a long time, and it's a lot of, orthodontic force and TADs and I mean, I had to close up spaces because of, treatments I did, and shit, that took a long time and it was very painful. So I can see and I still have a little space and I don't mind it at all. So I can see how leaving spaces and then working later with them could be an option. What do you guys think about FME for aesthetics in general? You only mentioned patients sort of freaking out because of diastema. What about other changes?
As a cosmetic restorative implantologist dentist, I really, really like the way it looks on the face. Obviously changes the facial structure, but also even dentally speaking, it winds up buccal corridors. And so you have a much broader, wider smile. And so when we design smiles aesthetically, whether we do veneers or crowns, I like that broader, wider smile. I kind of lift the smile and the lips up a little bit. So it gives me more runway to actually design the smile aesthetically.
And you've got to have really good initial smile diagnostics so that doing this for smile or facial aesthetics can be also tailored and case appropriate.
What is a good candidate for FME or MARPE? Let's just be general here. MARPE, who does well aesthetically with MARPE? Who does poorly with MARPE aesthetically?
Well, I think that's it's a whole topic. I think we could touch on it by saying that if we understand the effects of the expansion that we're proposing, then that might be a factor for case selection with the type of appliance you might use. For example, vertical control, we typically do see a little bit better performance with FME.
What do you mean by that?
Vertical control of the midface, right? So the tendency is for midfacial expansion to cause a little bit of a down and out movement of the maxilla. Oftentimes it's pretty neutral, it's facially tolerable, but maybe something isn't so neutral and facially tolerable, A, if it goes too far, or B, if it's on a face that already has some gumminess or anterior vertical excess or susceptibility, right? It's at least a consideration. Again, this all now matters in the global context of things. How much of that gumminess is what we would call, just short teeth, short clinical crowns? How much of that is what we call altered passive eruption, right? How much of it is skeletal, like true skeletal size and position? How much of it is the growth pattern? How will it look when it's advanced or rotated? If surgery is an option, is surgery perhaps more, likely to fix that part of the problem so that we can peacefully expand, knowing that the patient is most likely going to pursue surgery to improve that aspect of the problem? Then expansion doesn't need to address or, factor in that if surgery is going to be intended to do that. But magnitude is definitely an important thing. Now, even for that, right? Again, very individualized, but generally speaking, excesses of expansion don't tend to look good. Okay, excesses of expansion generally for most people don't tend to look good. But I have among the most expansion of anyone who's done FME. And my face is still a stupid face, as I tell everybody, but it's at least, I think for me, this suited me. I was so compressed. I was so narrow. I could tolerate all 9 millimeters of my expansion. And generally speaking, I think the reception to the facial changes I've experienced has been positive. Again, I'm no good self-appraiser of my face because I see the same stupid face when I look in the mirror every day.
But I mean, as somebody that's known him for 20 years, and somebody that's kind of, this is my career too, aesthetics, he looks, I'd say, more robust. I really like the way the cheeks and the face look with the expansion on them.
Yeah.
Now I just have to get working on the orthodontics because it looks kind of hillbilly-ish at this point.
Yeah, you don't want to judge the aesthetics of a MARPE case, when the teeth are all spread apart.
Absolutely.
Because obviously, when you size someone up aesthetically, it's kind of a three-dimensional thing, and you can't kind of factor out the teeth. And right now, the teeth, obviously, there's 18 months of work there.
And it's important to, I think, stratify facial and smile aesthetics to the extent that they can be stratified. Sometimes they're, of course, feeding the other, but they're maybe distinct in a way, right? So somebody's smile corridor and, sort of our diagnostic evaluation process of the smile corridor is one thing, and of the face and the facial architecture is another thing.
Yeah.
How might skeletal expansion, as it's classically, carried out for most people, how might that be anticipated to modulate those two things? That's basically part of our workup,
right,
and evaluation.
How are the aesthetic outcomes of FME different than the aesthetic outcomes of your typical custom MARPE?
I would say actually for the most part, they're the same. For the most part, they are similar. Most, again, this is me sitting here saying that most custom MARPE cases, we still do custom MARPEs for a lot of patients. And custom MARPEs generally tend to deliver very good results. And they are predictable, tried and true. Of course, we've spoken in the past about, different details in their designs that might be able to be used or leveraged to try to, alter the mechanics of force application in the midface. But for the most part, we find that most people doing a, modest or routine amount of expansion tend to respond similarly in that regard. But of course, there are certain things that, again, we remain a little bit bullish on FME, especially now that we've done a fair number of them. There are convenience improvements with FME in terms of, just not having to have separate appointments to cut arms off and this and that. There are practical things where that all your expansion is coming, from this, direct, skeletal point of force application.
As opposed to dental anchorage?
As opposed to, hybrid anchorage, right? Because it is hybrid anchorage. It's still anchorage. So that's why it actually works arguably more predictably in the case of custom MARPE. I think I'll also put this out there that I think our 2-3 cases, I'll say, I guess it was three cases that were absolute failures. I can sit here and say they probably wouldn't have failed to split, because I call an absolute failure a total failure to split the mid-palate suture. That probably wouldn't have happened with custom MARPE. But, I think for, we're trying to kind of course, understand some of the variables of why that is. You can spread your anchorage around any way you want. We have a lot of patients with some really good MARPE results. But some of our results that we are not as proud of are also custom MARPEs, right? Some of the ones that did get some inopportune, deviations from, the intended vector and behavior of the expander. I think a key variable there is the lack of guide stabilizing rods in MARPEs, right? So MARPE, you got pretty robust, rigid, strong expansion, screw apparatus. You have all this advantage of conformity to the palate and its anatomy. You have all of these types of things that you can customize and, really optimize for expansion. But I think that some of the forgiveness in a custom MARPE to continue activating when it itself can destabilize, I think is responsible for at least some cases. Of course, placement and planning from the front end is another, but that's a controllable variable.
Piggyback what he's saying, essentially, when the FME stops turning, it stops expanding. And if you kind of force the custom MARPE, it will kind of go where the path of least resistance is, essentially.
Right. So the guide rods are kind of a safety mechanism to prevent asymmetry?
I wouldn't say their primary purpose is to prevent asymmetry, but their primary purpose is to promote dimensional stability of the expander, which then in turn tends to promote prevention of asymmetry. And that's why we haven't seen catastrophic asymmetries with FME.
You have not?
In any patient. We've seen some asymmetries, manageable asymmetries, a little bit of, and we'll show some of the cases. There's some cases where, you might still get a little bit of that yaw deviation. You might get a little bit more lateralization of one side than another side. But these things are usually clinically insignificant and manageable, especially, again, in the grand context of what we're trying to do for the patient. That's also another variable, obviously. But we haven't seen any of these like massive, like, oh my gosh, like what is going on here? We've had one case in a prior jaw surgery patient where the device really started tilting pretty aggressively. So we aborted, right?
The FME did?
FME did. What
happened?
Well, I think the screws on one side, I think, got, basically one side just didn't kind of stop moving. I think we attribute it to, that was a 3.5 model. And the 3.5 model, we didn't really have the luxury of having oblique or angled TADs for septum avoidance purposes. In that case, you might have certain areas where you might tether into some of that bone or even, cartilage of the septal base attachment. And you basically, you might be on a small scale causing a little bit of a tether to one side that allows the other side to kind of move and drift a certain way.
And also the new 4.5s, we've kind of worked with Phagenics to pre-expand the expander when we put in to avoid the septum.
Right.
So septum avoidance is important. And that's, of course, with a custom MARPE, you're always going to get septum avoidance unless, of course, you intentionally try not to for a strategic clinical purpose of trying to correct or manage an asymmetry. But other than that, the default is oblique, septum avoidance, right? So I think septum avoidance is certainly important, and I think it's what we attribute to the cases that have showed some like little bit of tilt and this and that.
So the nearly 100 cases, 98, some of them were the old 3.5 model and then now the 4.5. So some of those issues that we were seeing originally with 3.5, we're starting to avoid the 4.5.
How many of the 98 are on the 4.5?
30 to 40?
30, 40, 30-ish, yeah.
Yeah. True or false that with the FME, the Phagenics lab basically oversees the cephalometric workup part of the treatment planning where you just determine where the appliance is going to go in the palate, how it's going to be oriented, the vector of the expansion screw, so that you're basically, the lab itself is providing an asymmetry prevention sort of stop, as opposed to a custom MARPE where you can have an orthodontist take a weekend course on custom MARPE and then they can start doing them, and maybe they don't understand fully how to orient appliances to prevent asymmetries, and then the lab won't interfere to say, hey, whoa, this isn't a great idea. This is going to end up exacerbating this pre-existing asymmetry. Is that true, or am I imagining that that's an important difference between FME and custom MARPE?
But what I would say is, as the dental professional, you are the captain. right? Your lab, whether it's Partners, Phasegenics, or any of the labs that I work with for implantology or veneers or anything you are the captain of the ship. So ultimately, whatever the lab sends it back to, you're still co-signing and approving it regardless of whatever happens. And so when you have a skilled lab and a skilled lab tech, whether it's Phasegenics or Partners or, your implant lab, it's a team effort, right? So, we're coming in with a clinical background and actually placing these devices in the patient's head and in their mouth, but we're also utilizing their skill set too, right? So for example, they'll be like, hey, you know what, why don't we pre-expand the expander, right? How many millimeters would avoid? That's something that they can easily come in and jump in and help us out with avoiding the septum, right?
Mm-hmm. Yeah, no, I think you said it perfectly. I mean, there's basically, like, I wouldn't necessarily characterize the dynamic as one lab or another lab having more or less, sort of control or, like, hey, something like, I mean, again, final approval with a lot of workflows and dental, in the dental profession, especially as they relate to ordering something from a lab, the final approval has to come from the doctor, right? So you could, again, Invisalign will send you a plan, the doctor modifies and approves it. Partners will send a plan, the doctor either approves it or modifies it and requests a modification. And their lab techs are very smart with accommodating those requests. And it is not uncommon that, we, will ask for, maybe their default protocol for designing and delivering their treatment plans is slightly different from the Phasegenics lab, but both are cognizant of and will yield to any requests that we have in terms of whether the alignment made or proposed is appropriate. And so again, there are just different protocols that probably both of those labs maybe use, or different conventions that they may use, different processes that they may use to determine what that midline is. Of course, we've come to trust, both labs in terms of their ability to, of course, provide us a pretty good plan, but it's our responsibility to check the plan and try to modify the plan as appropriate for the patient, which often involves like, hey, I need to see, how this looks relative to all of these other cranial structures. I need to see how this looks, and of course, in the Phasegenics planning, as maybe some of the viewers of this podcast have seen their own plans or other people's plans, and you can see that there's a lot of there's a lot of work that goes into those plans. And also similarly, people who have seen their own partners' plans, they'll see that it's a multi-page document showing you pictorial representations of each screw and the skull. And, we just have to know what each lab's process is so that we can tailor our communication to the lab to include all the things that we believe to be clinically relevant in approving the design and placement of an expander. So that's what we do. That's just the process.
Can I just say a little bit more of where I'm coming from with that question?
Sure.
I'm looking for a solution to being able to scale skeletal expansion while avoiding the asymmetry problem, basically, right? Because the asymmetry problem has been a big one the last several years. I thought, and from your answer, it doesn't seem like I was affirmed in my thinking. I thought that part of the value of the FME, of course, it's more expensive and all that, and we'll talk about that. I thought part of what you were getting was that you're essentially decoupling the cephalometric orientation planning part of the expansion from your provider, so that you could basically, if you could go anywhere in the world, and as long as it was an FME provider, you could trust that that was being outsourced to the lab itself, where there was better software and a better system for orienting the CBCT, taking the STL files, and creating a straight, even appliance, as opposed to custom MARPE, where it's whatever the dentist tells them to make, they're going to make. But am I incorrect in the way I'm thinking about that flow?
You're not entirely incorrect, but I think what we've both said is true in its own way. And what I mean by that is that still final approval has to come from a doctor. And yes, we find that the, Phasegenics lab planning process takes a lot of things into account. And obviously that's why, one can, feel pretty good about the plan coming in front of them, but you still always have to double check it for appropriateness, right?
Have you had to fix Phasegenics plans in the past?
We've had to modify some plans.
At the same rate, in the same percentage as as the partner's dental studio plans?
I would say because of the nature of custom appliances being custom, we tend to order more modifications of custom appliances, only because certain cranial alignment things aren't necessarily default with their original plan. So again, that kind of goes back to me saying that we might customize our communication style with the lab based on what we know the lab is going to provide us. Phasegenics is already, their lab is already doing a lot of, those cranial alignment things and showing how they do it in their software that perhaps reduces our work. Plus, we can't customize the appliance. So all we can really dictate is how far left or right or front or back to place that very appliance. And that's it. That's really, so as far as your question about the practicality and scalability and maybe protection against providers being subject to having really, kind of off-kilter plans, you're mostly going to be protected from that in Phasegenics. So as there become, we're not going to be the only providers forever. There's going to be other providers that are going to be able to basically, rely on, that.
Well, I mean, I'll take a different approach. Invisalign's a prime example, right? Most patients think that going down the street, shopping around, they're going to get the same Invisalign plan, right? And that's not true, right? What the lab will send back to the doctor is different based off the doctor's preferences, and then the way the doctor designs the smile and the case changes the Invisalign outcome. So just going shopping around for Invisalign is not the same anywhere. And so yes, the Invisalign lab is very robust. It's amazing features, but it depends on the doctor you go to.
I guess what I was thinking was that custom MARPE was sort of more like Invisalign, where they'll make whatever you tell them to make. And I was thinking of Phasegenics more as like...
there's still a lab. They'll still, if I want to turn an appliance one way or the other way, they'll still do it. They may, of course, their lab techs or engineers might come to us and say, "Are you sure you want to do this?" That would make.
And then that's the benefit of working with a lab that you're close to.
Lab.
Is that it's a team approach
with partners and Phasegenics. And
Invisalign too. I mean, we'll literally get on the phone with Invisalign clinical doctors, and then they'll be like, "Doc, we'll go back and forth with that too." And most people probably don't even know that you can actually talk to an Invisalign doc that works for Invisalign, but you actually can, to customize the actual movement of the teeth. And this applies to clinical dentistry too.
So yes, there tends to be more customizability with things like moving teeth or things involving what, teeth you can attach appliances to. How do you want those bands and connections to be designed? How do you want, the arrangement of your screws? Because it's custom, there's a lot of opportunity for interplay. Obviously, with Phasegenics, it's just a little different because of the nature of the appliance being prefabricated. But as far as so then the question becomes, I think, a relevant now follow-up discussion point to that is that sure, Phasegenics' lab and planning process does do a lot of that front end work, and we of course have to appraise it, modify it, whatever, as we customarily do for any lab workflow. But on that token, we have a lot of experience doing FMEs, right? We have the most experience doing FMEs. I think
by an order of magnitude, by 10x.
By order of magnitude, by order of actual engagement with their company and their engineers. There has been nobody in the history of Phasegenics' existence that has interfaced with them more than we have, and we have provided the highest level of feedback, experience, this, that, whatever, to come up with some of these design iterations and improvements and all that kind of stuff. And, we maintain a very good relationship with their main engineer to come up with a lot of these things and continue to develop and design the appliance to work really well. So what I mean by all this is that, sure, you could take the competency of the lab and you could put it in the hands of an inexperienced provider. And sure, you have to, all experience starts somewhere. So that provider will gain experience. The provider will gain, the process and workflow of working with the doctor. But of course, experience counts for something, because we see some of the practical challenges. We see what happens when, a device, kind of torques out. It's so difficult to remove a screw. It's, all these kind of things. They're just like little things that end up becoming, relevant in the clinical management of a patient. And so obviously we today have much more experience than we did 18 months ago, obviously, with FME. So we have accumulated that as a result of this interplay, as a result of the experience, as a result of working with so many different patients with so many different kinds of skulls, age ranges, demographics, this, that, whatever. That, I think that it counts for something. But as far as just like the lab and the planning and the installation is actually a relatively small part of FME. And I think that's what a lot of the viewers of a podcast like this may not necessarily appreciate. There's a lot of back-end administrative, back and forth with a patient to determine the appropriateness of a treatment, answering questions, training our staff to answer questions on our behalf about things, and being able to field, these are big decisions for people, obviously, right? You're making a decision to restructure your face, at least in a small, modest way, or perhaps in a very significant way, to support some sort of breathing, functional, or in some minor cases, aesthetic goals, right? And if you're doing that, well, it's a big project, right? There's a lot that goes into it, other than just, I'm going to submit the DICOMs to the lab. They're going to send me a plan. Any doctor in the world could approve that plan and then put it in. Like, to some extent, sure, but then what? Like, how do we manage those discussions? Nobody has any idea how many questions we get asked about the timing of doing this or that orthodontic thing after we've expanded, and how this relates to the jaw surgery, and how this relates to...
I'll give one example. Was when we first started doing the FMEs, the patients, we would instruct them to start turning immediately, right? And so after gaining clinical experience and seeing some of the complications post-op, we started slowing down, because after the piezo cut, the soft tissue would need to close up before applying force and opening everything back up. And so...
Otherwise, you might get a non-union of the soft tissue.
Correct. And so those things, that came from experience. Okay, let's slow down. Even for the custom MARPE, a lot of the failures that we had were the aggressive, quicker turning protocols that majority of custom MARPE providers were doing years ago.
Which is so the 2022 version of us.
Yeah.
2023.
So
right?
We're wiser. We've seen hundreds and hundreds and hundreds of more cases, right, to be able to kind of deviate from what we used to do before. Yeah. Also, another thing that what Dr. Newaz was talking about, each plan is super customized to each patient. That includes the turning protocol, right? That includes how often they're turning, how much they're turning, things like that, right? And so each patient's different. And so just delivering the expander is one component. And yes, having almost 100 under a belt helps with that delivery component, but it's after the delivery also, right? That's when the actual expander is working.
Why would turning protocol change patient to patient?
Going back to before, some patients feel a lot more tension. Some people feel a lot more pain. Also, you're literally expanding the jack screw. The jack screw is taking that force. That has to translate into the maxilla. So sometimes, each person, the way their body's responding, you may want to slow down the protocol for basically the jack screw and the body to catch up to each other.
What's the standard operating procedure in terms of protocol? Where have we settled in 2025? August 31st, 2025. Is it a turn every other day as a default? Is it, one turn every day? Is it Juan Moon, 5 turns a day, and when you feel like you should stop turning, turn it 5 more?
We definitely don't do that.
I mean, I even heard Audrey Yoon say that she wishes that we would stop calling it MARPE and start calling it MASPE, microimplant assisted slow palatal expansion. Are things trending slower?
Yeah, we're definitely going a lot slower than we were a few years ago. And even with the FME, we're going a lot slower than we did a year and a half ago.
How slow is slower?
I would say initially after the split, after delivering the appliance, we want the soft tissue to heal. 1 week, 2 weeks? We're waiting about 5-ish days.
5-ish days, no turn after midline piezo cut and FME install.
Yeah. And even with that, when I deliver it, I'll say, make sure, obviously you're keeping everything super clean. But when you're using the water pick, use the gentle setting. We don't want the surgical glue to be removed too quickly.
Well, you glue the mucosa shut?
Yeah.
After the piezo cut?
Correct.
Do you score it with I guess scoring, it's not the right word. Do you slice the mucosa with the scalpel first?
Yes.
And then you go in with the piezo?
Correct.
It makes for a better healing site?
Oh, sure does.
Yeah.
Much cleaner soft tissue approximation.
Yeah. Does it also help you mark your line?
Oh, it sure does. Yeah. Now, and I want to make also another small technical comment about, this whole waiting for soft tissue closure before turning kind of thing. With a custom MARPE, you can pretty easily see and access most of that cut line. So classically, wasn't that much of an issue. Yes, we did have some patients with soft tissue perforations and stuff. You got to, close it, reverse turn, whatever, and make sure you have really good soft tissue closure before you expand. So in general now, whether it's a MARPE or an FME, you have a need to maybe wait and, because the sort of scoring that you've done to the bone will render the bone weak it's not going to go anywhere as far as it's not like it's going to heal, solidify back up in 4 or 5 days.
It heals slower than the soft tissue.
It sure does.
So you use that differential to kind of allow the soft tissue to heal while still taking advantage of the scoring of the bone.
Correct. And with FME, one of the different things about its geometries, I guess, is that it doesn't totally conform to an individual's palate. So because it doesn't, there is more leeway for, food particles and this and that to get stuck in there. There's, and obviously because you have the top of the box screwed into the bottom of the box, you have a visualization issue. Now you have an easy way to create visualization by popping the top off.
Popping the top meaning expander.
Yeah.
Yeah.
Right. So the expander module that locks into the plates, you can take it on and off so you can have access, but generally once you put it in, right, you're not just popping it off all the time.
How many times have you actually popped off the expander body off an FME?
I've definitely a bunch on Lauren.
Oh, really?
Yeah. Well, when we delivered my wife's expander, we didn't realize she was pregnant. So she had a lot of food aversions and things like that, and she wasn't healing up as quickly as most of our patients. So I did pop it off at least twice, I think, to clean underneath it just to see how she was healing. Mm-hmm.
But generally, not maybe a lot.
Yeah,
not a lot of actual situations where we have to do a lot of that.
Especially with the new protocol around
waiting.
Yeah,
exactly. And also, as you expand, correct me if I'm wrong, it's easier to clean because now you have more space.
Yeah. Like in yours is wide open. There's access everywhere.
Access.
Versus
a little better
when you
access,
first deliver it, everything's closed up. It's much harder to clean underneath it.
Right. Out of the 98, how many of them were no piezo? How many of them were just midline? And how many of them were something else?
I would say probably only about maybe 5 are no piezo at all.
And were those a long time ago?
No, they're actually more recent.
Oh.
In the beginning, we were just doing piezo on everybody just to make sure it's a new paradigm. There's no collateral anchorage anywhere else, right? We want to make sure that people split. So we're doing the piezo corticotomies on just about everybody. And then we started seeing, hey, like these devices are indeed pretty robust. They're powerful. So some of the patients that do meet certain, requirements of being young enough or having bone that's thin enough or whatever.
Female enough.
Maybe female enough, right? Even though, we have a 27-year-old male that we recently did no corticotomy on who's split and is having a great sort of first ride in his expansion. What appears to be, at least from the most recent status updates that we've received. So, we're starting to see that we can maybe push the envelope on that a little bit. We're still mostly just recommending it, but we'd love to not have to a lot of the time, just because it's an extra procedure, it's extra trauma, risk, whatever. So the least you can do, the better. So we're
there's a balance. Obviously, you want to make sure
it's successful.
Nice. So what about this business about there being too much surgical assist for sometimes for FME? I have a person that I know who had an ease with an FME and developed symptoms that may potentially, and this is speculation, but may have been related to too much surgical assist and too much activation of the appliance immediately following the surgical assist, which is to say overcompensation, more of the latter?
More of the latter. It wasn't necessarily that the surgical assist procedure was too much in some fashion, but it was the activation. Because again, you're taking a very robust parallelizing device, and you're activating it real time to produce a diastema instantly in the operating room. We don't generally find that to be an appropriate protocol with FME, just because it transfers up to the midface so efficiently because it's so rigid. So you do have the potential to sort of put some pressures or strains or compression on, orbital, structures and nerves and muscles.
So anatomically, how does turning slower kind of mitigate against that? Like, is it just a matter of the rate at which force is applied to bone, and then the bony material just responds differently to less force over time, or?
Well, yeah, usually, a lot of structures in the body respond a little bit better to gradual types of things. So so in the case of expansion, right, what particularly does slow expansion help with is not over compressing structures in one go, right? For example, right? And giving maybe some of those soft tissues some time to react to the changes that might be happening in the bone, but you want to give those bony changes time to actually express, right? So one thing is activating your device. It's not that in real time everything in the midface is just moving commensurate to the activation you just made in the device. That the upper midface will follow after force transfers and dissipates.
And going
tension
back,
dissipates.
The screw is turning. So what I kind of do this for patients, like the screw is turning, it has to translate into the maxilla, into the jaw. So from what we've seen, the longer you wait between turns or the slower you go, there's more of that transfer happening, right? And so some of those initial failures or outcomes where the screw wasn't turning, we're seeing that the screw is now more able to turn because the force is now translated into the body.
Yeah, it's almost like, and correct me if this is not the right way to think about it, but it's almost like bone is more like wood than it is like stone, where there's when you knock it, you get a knock. It's definitely a solid material, but there is also some bend and some play there. Yes. Maybe it's like a hardwood. It's an oak and not a pine, but it's...
it's interesting. We're talking about, I guess, macro, but even micro, when we're placing the screws the TADs into the maxilla, that in itself, the slower we go, the screw drives better too. It doesn't stop out. And so those are the clinical things that, we've kind of experienced. So for example, if I'm doing, the MARPE or the biomaterials Korea screws, the slower I go on, the longer TADs, the better they are, right? So when, I'll do a hand wrench for a majority of my MARPEs, because the way the TAD goes in, it's very slow and the bone is nicely expanding and kind of allowing the screw to come in. And so when I first started delivering it with the electronic driver, a lot of them would stop out maybe 2 millimeters shy of going down completely. And then you just kind of stuck. It wouldn't go down more. You couldn't reverse it. I mean, when you finished, you'd come out, but in the initial delivery. So now those are things that we learned, just like you were saying, the wood is different. Going slower may be beneficial, right? And that's a micro.
No, it's a case in point, though, in terms of the way you identify these sort of subtleties and nuances.
You feel it. Like we done hundreds and hundreds. You can feel it in your hand. You can feel it in the e-driver, right? And that's one of the subtleties you get when you've done so many of them now.
Yeah, it's the way you talk about it is almost like the way that a really experienced woodworker might describe something that you could never learn in a book about how to drill a certain type of screw into a certain type of wood.
Same thing. You could feel the bone. You can kind of sense how it's responding to the piezo cut.
Let me pose a hypothetical to you guys. 45-year-old male wants an expansion, pretty tight palate. Do you think that a more extreme surgical assist, such as a pterygomaxillary release, an ANS release, and a midline release, would be more likely to be beneficial as opposed to just a midline cut with FME? Or do you think that, to my earlier point, that pterygomaxillary release is actually contraindicated with FME?
I wouldn't say anything is categorically contraindicated, but kind of off of what we were saying before, we've just found certain cuts simply not to be necessary with improvements in a device and a workflow. A custom MARPE or really, or basically a custom MARPE or an FME that are both otherwise have the characteristics that they need physically to be, conforming or at least almost conforming enough to the palate in the case of an FME, which can't be exactly conforming, and having available bone anchorage that's adequate. Usually, the mid-palatal is enough. Maybe sometimes a little bit of an anterior, which, we'll do here and there in a blue moon, but that's it. That's, again, and we're navigating those waters and seeing. Pterygomaxillary, on the other hand, again, is generally not necessary to produce really good skeletal expansion. I'm 38 years old. I didn't get pterygomaxillary release, and you could sure as hell see my pterygomaxillary sutures separating. And that being, the basis for the 3 to 4 millimeters of anterior skeletal movement that you're going to find in there. With me only having worn the FMA for maybe a few minutes, really, if you look at the cumulative time. So it's not because of FMA. We'll just put that out there too, right? For me, again, FMA, as we've talked about on a prior thing on our own channel, was mostly an experience-driven test drive. But I think practically to actually get protraction, maybe it could work if I were really dedicated with it. But I think there are there are certain practicality concerns with traveling with that thing and this and that and everything else, and having the time and the consistency at my age to be able to do it for long enough to actually get protraction. Lifestyle. I already got 4 millimeters. I that's good enough for me. But basically where I'm going with that is that pterygomaxillary release surgically is generally just not necessary, MARPE or FME.
And also, I think some of the providers that don't do the piezo cut, they'll recommend dome. Now there's some complications that come with that too. Sometimes the bone doesn't heal properly. It's also a fully surgical procedure that has to be done in the OR, right?
I'm sorry. Why do they pendulum back and forth between two extremes of, oh, no cut, or it's either no cut or it has to be the most invasive possible cut?
I mean, practically speaking, not everybody's comfortable doing everything. And so I could see that where, doing a cut is a surgical procedure, right? So somebody like myself and even Dr. Newaz, like, I pull out teeth very frequently throughout the week. I place implants multiple times a week. You know what I mean? So for me, the surgical component is not that, doesn't scare me, right? And same thing, he's a well-rounded orthodontist, radiologist, and he's practiced general dentistry before too. So for us, I don't think it's that quote unquote big of a deal to do the piezo cut. But I could see where for somebody that doesn't do this often or is experienced in surgical procedures would be a little shy from doing that.
Yeah, but why?
And then for them, the other option is refer to a surgeon that would do a more aggressive cut.
The surgeon just defaults to the full-on.
Depends on the surgeon, obviously, but yeah. I mean, if you're going to kind of go underneath, general anesthesia, make sure it's 100% successful, I guess.
Right. Yeah. I would hope that there would be a middle way there where you could, if you're not comfortable doing the piezo, you could refer out to just a midline cut or a midline ANS.
Which can be done. I mean, we've done similar before if we need to maybe include one or both sides of the pterygomaxillary. I've done a case recently collaborating with a surgeon where I went to the operating room or their office. It wasn't like a general anesthesia OR, but we went to the office and then we did we installed a MARPE to try to correct a very prior a prior really sort of pronounced asymmetry. So we just did a unilateral disjunction of the pterygomaxillary. Obviously, I don't have the skill set to perform that, so I needed the surgeon to do it. Obviously, when the surgeon's there, we're doing the mid palate and we're doing the right side pterygomaxillary, and then we're putting in our expander. So I was there to be able to actually deliver the appliance after those surgical cuts were made. So we have collaborative experiences like that where we'll actually go to surgeons' operating rooms and do these sort of collaborative procedures, and it's really helpful to actually see. It's really cool. And also humbling to see that, hey, like these guys are legit. Like they have a very different level of medical training and experience with, doing certain, bone cuts. Of course, for us, we're going through oral mucosa. We're maybe just about as good as anybody at making a mid-palatal cut, because that's kind of a straightforward procedure. But, when it comes to, having to tap things open and, make cuts in more anatomically sensitive areas. That's obviously, we don't go near that stuff. So we love to collaborate with our colleagues on those types of cases.
So did you just say that you attempted a asymmetry reversal? So
Yes.
There was an asymmetry that was caused by a MARPE?
Correct.
Not your MARPE, someone else's MARPE?
Correct.
And can we double click on this case for a second? Because I think a lot of people are wondering about the potential for MARPE to reverse asymmetries. Obviously, when you get an asymmetry with a MARPE, you're stuck between a rock and a hard place because really the only known way of potentially fixing that would be with an orthodontic surgery. But you're talking about using another MARPE to correct an asymmetry caused by a former MARPE. What happened? What was the specifics of that asymmetry? What did it look like? How do you think it was caused? And then what did you do to try to guide the new MARPE to reversing that?
That's a great question. And I want to just kind of come out here and say, like, we're not necessarily out here trying to say that the standard way to manage or deal with prior MARPE asymmetries is doing another MARPE. to try to correct it. But it does appear to be one tool that can be used if clinically appropriate and if there's room for additional expansion to really kind of try to shear one side of the maxilla off of the other, especially when a lot of your asymmetry was in the yaw direction.
What does that look like?
So the yaw direction is basically like when you're looking at the maxilla, you know, from the bottom, then if one side is eccentrically more bowed out than the other, which may, in terms of skeletal asymmetry, show up as both the arch being yawed and also maybe a cheekbone being more out and forward, creating a depth problem.
It's not a cant thing, it's a depth thing?
A depth thing. Well, of course, there's also the cant thing, which can also be attempted, you know, with the certain vector of the appliance. So, but, you know, definitely the yaw thing seems a little bit easier to fix predictably with something like this, because you can point the jack screw so aggressively anterior on the other side that you can just simply, again, shear it off and correct it. And then if you really need one side to swing off, like let's say, you know, you're looking at, you know, your before and after CBCT or a superimposition, you can literally see one pterygomaxillary suture disarticulating and the other not. Then that's now become the weaker winning side for the remainder of the expansion process. So to offset
is that what causes a yaw problem? Is a unilateral
often yes,
pterygomaxillary?
Often yes.
Frontomaxillary is more of a cant.
Yes.
And pterygomaxillary is more of a yaw.
Yeah.
Asymmetry.
Correct.
So you, on this patient, went to the unyawed side,
Yes.
and you released that pterygomaxillary suture.
Correct. After a period of consolidation after the first expansion, because everything's still kind of weak for a while. So we waited,
6 months?
I don't know, maybe 8. Yeah. I mean, the more the better, really, in that case. But yeah, I would say 6 is a minimum. 6 to 9 is reasonable. I think for this particular patient, it's definitely more than 6. And yeah, basically now we get full healing. You can confirm that radiographically compared to priors, and then you can see that, okay, hey, now let's separate the right side and try to, you know, bow that out.
What did that appliance look like?
That appliance looked pretty wild. So we have, you know, we had actually a 45-degree angulation of the jack screw.
Custom MARPE?
Custom MARPE.
This is really where custom MARPE shines.
Yeah, it is.
Is true. You can't do that with an FME.
No.
Case in point as to why FME is not always going to be the answer.
Correct.
So you told Partners Dental to give you an appliance that looked like this?
Pretty much, yeah. So, I mean, literally the jack screw is pointing 45 degrees anteriorly to the side that we want to move more anteriorly.
What did you do with the TADs?
Yeah, very good question. So what we did was we also find, especially if we see the septal base attachment and we see that one side of the nasal fossa is a lot wider or narrower than the other, right? So in this case, let's say the left side, which moved out a lot more, also happened to have a greater distance between the septal base in the midline to the lateral inferior corner of the nose, right? And so if you look at that distance, right, that distance being so much longer than the right side one, well, then one of the things that we can at least attempt to do in a situation like this is to try to use the septum from which some resistance can occur in expansion, as we've experienced with some of our cases.
It acts like a kickstand.
It almost acts like a kickstand in a way. And so you can actually put a couple TADs in there. So out of the 4 TADs on that side, I put 2 of them engaging the actual septum base. Okay. And then on the other side, you know, we arranged the TADs in such a way where we got really good anchorage where, you know, we wanted to go out. Sometimes the assortment of bands, you know, might be a little bit different or asymmetric too. You might do like a second molar and a second premolar on one side, maybe a first molar and a first premolar on the other side. Something, you know, just things like that, so that what intuitively looks like would be the behavior of the appliance will be in the direction that you're trying to move the midface. And again, by doing 45 degrees, every turn that you're making, you're not making 1 millimeter of expansion. You're making less than 1 millimeter of expansion, which is usually good for cases who have already expanded and you want to, you know, actually mitigate the lateralization aspect of your expansion. You're really more actually going for, yes, let's get expansion in the sense that we can get a split, so we can get one hemimaxilla to move, but we don't want so much lateralization that we're overexpanding a patient, right? So again, there's runway with even being able to be more aggressive than 45 degrees on the yaw angulation.
And if possible, maybe we can share the design, like a picture of the design.
If you send it to me after we stop
We can do
recording,
that.
I can
We can
throw
do
it
that.
in post.
Sure.
We can anonymize it as needed. Any indication as to how that's unfolding?
Well, I mean, it's very early. This was literally done like a couple weeks ago. So,
Okay.
So we're waiting to see, but we did get the initial split. Again, because it was a more intense procedure. Took it easy for a little while, and then basically starting the process of turning. We got the split. Now we just need to see how it carries out. But we're very excited to see how that turns out. But for similar cases that we've done in the past, because this is not the first time I've done an expander like that. It's the first time I've done one where I've actually showed up to the operating room in one of these things where we're doing the pterygomaxillary disjunction and the midline cut and delivering it in real time. But what we've done for some other patients in a sort of sequential manner is like, hey, we get a little yaw to one side, so we take it out, and then we'll put something else in that kind of goes the other way. Or, we'll pull back the first one and then we'll put something else in that goes the other way.
Mm-hmm.
And again, you just have to make sure that your variables of time and sequencing and anchorage and all that is appropriate for that situation. But we've seen a decent amount of success with it, but it's still not so predictable that I'm going to sit here and tell people like I can reverse your MARPE asymmetry like no matter what. Like it's obviously we're still learning that. We're still doing our best to try to find what actually works and what doesn't, because our enemy here is Newtonian physics. No matter how you slice it, you're pushing one side off of the other. You could put all the boots and anchors you want into one side to try to prevent it from moving. It's you're going to struggle to make it not move at all. So to really shift the balance, there are other things you can do. And of course, I've spoken in prior episodes on maybe our own channel and even the time that we sat down that extraoral force application is a powerful modulator that we at least have to be able to try to shift the balance in favor of one direction or the other.
Mm-hmm.
So we put face mask hooks in this individual's MARPE so that she could, really pull one side out. So we need a lateral vector and a forward vector for that to work, so that basically the desired hemimaxilla that you want to move disarticulates at the pterygomaxillary junction and swings out.
Mm-hmm. Mm-hmm. That's very exciting and that's very interesting. And I'm be curious to see what the imaging on that case looks like. 3 months from now.
Yeah.
Or even what that
100%.
custom MARPE looks like.
Yeah.
Maybe you could get me an image of that for post.
Yeah.
Now what I would like to do is I would like to look at your case. Let me fire up the screen recording here, and then we'll take a look at your case if you're cool talking about it.
Yeah,
Do you consent?
very much so. I
Consent
do.
to have your images shown?
I mean, his whole surgery was live streamed.
Yeah, it's
That's right. And your YouTube channel is called?
Airway Ortho.
All right, everyone definitely check that out because there's some really awesome exclusive FME, FMA content on that channel. But let us do a JawHacks look at Dr. Newaz's case. Let me just fire this up. So this is you here, Dr. Newaz?
unfortunately so, yes.
So let's just do a quick look at the airway. This is your profile view of the airway. So what are we seeing here?
So you're seeing basically this is the Anatomage in vivo software. So I did, and this is what I classically use for my analysis and radiology reporting stuff. I've just gotten particularly comfortable with this software. I don't think its superimposition tool is best in class. I think perhaps Dolphin has a little bit better superimposition tool because, of course, it was made for an industry that better benefits from superimposition as a evaluation tool. But anyways, all that fluff aside, what you can see here is if you have your eyes fixated on the cranial structures, if you look at the posterior aspect of the cranium, and you look at that sort of sella, and clivus area in the middle of the skull, you can basically see that these two blue and white images are pretty well aligned, right? They're as well aligned as I could get it with manual superimposition.
So where are we looking? Are we looking in this area where my scroller is?
Correct. Okay. And then, so basically, the white image is the before. That was just before I had any treatment. And then the blue is that was taken, I don't know, 1 or 2 weeks ago or something. And also, I'll probably say 2 weeks ago, because time flies in my orbit in ways that I have learned not to, try to track too well. But time flies really fast for us because we're always moving. But anyways, blue is after. Blue is very recent. And then you can kind of see, of course, what's happening with a lot of the structures. One of the things that I want to kind of focus on, Ronnie, if you could pause the video at a certain point where you can see a little bit of blue and a little bit of white at the same time. If you maybe take there you go. Right. So this is actually a good representation where you can actually see, okay, hey, the structures that are really well registered, well, you don't see any double outlines up there in the cranium, right? But you do see double outlines in other areas, right? So what does that mean? It means that those structures moved. Obviously, the double outline you see in the C-spine is just a result of my head posture being a little bit different. Because my head posture was a little bit different, I'm not going to make any claims or make any sort of inferences about the pharyngeal airway size or volume. It's just not going to be appropriate to do that because my neck posture and head posture was slightly different for the scan. It wasn't wildly different. And I think one could extrapolate that, I had a net positive pharyngeal airway effect, but I'm not going to comment on that for the purpose of this because my C-spine is a little bit off, right? Mm-hmm. But what I can comment on, right, is obviously independent of head posture is the movement of the maxilla, right?
Just to pause, the point you just made is a really important one because I think a lot of people will take a side profile view of a scan like this and they'll make an entire diagnosis about a patient's airway based on this view right here of this tube, the pharyngeal airway, when this tube and how it appears on a scan is tremendously impacted by this.
Yes, it sure is. In a big way. Mm-hmm. And other factors like inspiration, expiration, all that kind of stuff, right? Tongue posture, so many variables. So that's why we use those as general guides to make generalities about categorizing a patient's maybe risk profile for sleep disordered breathing or something. You
kind of look at a scan like this, kind of note the position of the spine, determine whether the spine is somewhat neutral, and then look at the pharyngeal airway and say, hey, that's a pretty neutral neck posture, and that airway is totally bunk. Mm-hmm. But a lot of times patients will tuck their chin like this in a scan, and then that makes the pharyngeal airway look artificially small. Because they don't go through life like this.
No.
Even though they may think they should because of some posture theory they have that they try to bring into the scan.
Yeah.
But anyway, all you're saying
said though.
All you're saying is we can't determine anything conclusive about the pharyngeal airway based on these two images because your neck posture did change. Mm-hmm. So we're going to look elsewhere. We're going to look here at the A point of the maxilla maybe. Here at the chin, and then we can, look at the joint later and see what happened in the joint into the centric relation or loss thereof. But please continue. And of course, we're seeing the FME itself here. This is the FME here, yeah?
Yep.
This block. Mm-hmm. But let me give you the platform again to just continue to comment.
Oh yeah. Well, you get to a pause at a point where you can see a little bit of both.
Okay.
Of course, in the animation, you can see a very clear forward movement of the blue compared to the white.
Which we see right here.
But now you can see in the double outline, and measured, depending on where you measure, it's about 3 to 4 millimeters advanced.
At the
8 point. Now,
so is this an AGA treatment?
It sure is not. Yeah, absolutely not. But this is basically showing skeletal migration anteriorly of the maxilla. Now you'll also see that the mandible came forward too. That is postural. So we want to let people know my mandible did not grow. It was simply able to posture because I felt so trapped inside my starting maxillary position that when I was in my full bite, right, maximum intercuspation, centric occlusion, then I was in a posterior of center position in the TMJs, right? So, right, you have the head of the jawbone in the socket. I was pushed back considerably in my sort of centric occlusion, right? And as a result of the maxilla now having created some overjet from my maxilla kind of coming forward, well, my mandible said, okay, I'll play. I want to walk forward a little bit. And again, for me, that walk forward was maybe just slightly more than what would be a very normal centered position. I mean, I'm certainly not terribly forward of center in my socket.
Are we seeing that here in this GIF?
Yeah, you can't really, I think there would be other GIFs that would be more appropriate to actually just show where the fossa is. You can't really see where the fossa or the socket is. You can definitely see what the condyle's doing.
Is this GIF courtesy of Shuikai?
Yes, it is. Credit to Shuikai for this and many of the other images that we're going to be showing today. My superimpositions aren't as good as his, but this is his. And so a few interesting things to point out in this, of course, and I won't belabor mandibular position. I think all that people really need to know is that, hey, if I have more clearance because my top jaw came forward, then my bottom jaw was able to sit forward. For me, that happened to be a more comfortable position and a pretty stable, reproducible position. And, you can see my occlusions basically just traveling about the same amount. And, for me, it works. For some patients, it may not work to come from a maybe centered or already forward position, more forward, right? Those are, of course, things to consider on the front end. So for me, that was very helpful. But anyways, I had separately, in a separate slice, measured my maxillary movement, not only to have come forward 3 to 4 millimeters, but to have had about a 1.8 degree counterclockwise movement. So my posterior maxilla came down. You can kind of appreciate that a little bit in this cartoon. If you're looking at this cartoon, yep. Yeah. So if you look at the hard palate and the way it's migrating, it's definitely coming down and out. Like that's what we try to achieve with double jaw surgery, counterclockwise double jaw surgery. Obviously, this is a much more modest movement in magnitude, but it's the same flavor of movement. And you can see what that might mean for, an individual soft palate, right?
Absolutely. The soft palate is moving too, obviously, because it's following the hard palate.
Correct. And imagine that, my tongue weren't further obstructed by this, mass of a device in there. So the tongue, would further be able to nest a little bit up and forward in the palate, allowing the soft palate to drop down and in away from the posterior pharyngeal wall, the upper part of the airway. Right there. Exactly. Right. So having the soft palate basically be able to, having the hard palate in the back be able to come down and out like that, I think is a very powerful thing for airway. But that's what we're seeing. Now, if you go back to the Shuikai cartoon that we were just looking at from the side view.
Wait, a couple of things. You also did MRI of your TMJ.
Yes.
So you want to talk to us a little bit about that?
Yes, absolutely.
Do I have that image or no?
You do not. I'm going to try to curate it or whatever and show you because, again, I don't have the viewer for that on my computer, but once I chop that up a little bit, I'll go over it with you. But you know, on the MRI, we were able to see. Obviously, everyone can see my mandible moving. Now, let me talk about that in just a second. I just want to point out a couple other midfacial things, and then I'll come back to the mandibular position. You know, so if we're looking at now, look at the you know, look at the zygo area, right? Right. Yep. And so if you go a little posterior to that, right? Yeah.
This suture here?
Yep.
Wow.
So, yeah, so look at that coming apart.
So this is true cheekbone enhancement.
Yeah, that's correct.
This is not a bony overlay or a peak implant.
No,
This is,
that's real.
was this anterior or was this more of a splaying kind of diagonal to 3 o'clock or to 2 o'clock or 10 o'clock type direction of this change?
I would say over here, it's more of a pivot. It's more of a rotation. It's more of a splay. It's not necessarily just breaking off of that and lateralizing like 1-to-1 or something.
And it's not.
Crazy
It's
like
also
that.
not a pure anteriorization of the zygomas. It's more of a this.
Yeah, I think you could say that. Yep. And you could actually see that it pivots about 2 points. So one of them is the suture we were just looking at. And then now look at the, you know.
Up here?
Yeah, exactly. Right.
Geez, man, that's way up in your eye.
So the frontozygomatic.
Wow.
That mid-face expansion,
True midfacial
you're
expansion.
expanding and kind of pivoting a little bit from the top.
Yeah.
And to the earlier patient.
Wider and frontal and angles up. So
Wow. The patient I referenced earlier who had the ocular problems with the ease plus the FME plus 8 turns at the moment of ease surgical assist, it's possible that these changes occurred too quickly and catastrophically without giving the soft tissues, the muscles of the eyes or around the eyes, a chance to acclimate. You did, maybe, right? But we can see.
Of course, this is, yes. The answer is yes, of course. To this degree, this wouldn't happen in the upper midface in intraoperative turns. But to some extent, you know, a lesser version of this could create those types of, you know, compressions and tax on the nervous system. And, you know, this particular patient was working with a very good, you know, eye physician on this. And, you know, I think proper formal diagnoses of, you know, strabismus were made where, you know, and then we could actually see that, you know, maybe 95% of symptom improvement came back when reversing the expansion. Then the whole idea was to sit there for a while before even attempting or contemplating any other expansion, remove the device, all of this stuff, try to normalize the most you can before making any attempt. And of course, any subsequent attempt, well, it better be done extremely cautiously. You know, and then, again, we always have the chance to just, you know, there's always the chance that you basically have to close it back. This was not our patient, by the way.
Correct.
We just happened to.
Correct.
study wins the race. I think
Yes.
that's kind of the moral of the story.
How long did it take you to achieve this magnitude of expansion?
Well, for me, you know, again, I've been sort of really lazy and inconsistent. I didn't really have one defined protocol. So what I did in the earlier aspect of my expansion, I just did your standard 1 turn a day stuff. I got the split. I maybe turned here and there, like, you know, every other day, whatever. Then I decided to try something called a burst protocol, which was basically, I was kind of getting a little bit bored of, you know, just doing those types of turns. So I said, you know what? When I make a turn, I want to feel a little more pressure. So I would make 2 or 3 turns in the moment, and then I would wait about the same number of days that I had made turns to then, again, let all that dissipate. And then I would just kind of continue that. So I did that for a time. I probably carried the expansion up to, you know, like maybe the first, I don't know, 2-3 millimeters. I did just conventionally, right? I opened up the expander. I did, your turns, then maybe up to about maybe, I don't know, 6-ish millimeters in the expansion, I did this kind of burst type of stuff. Because again, it doesn't take that many bursts to get there. If you're talking about doing 3 turns in one sitting, that's like, 0.4 millimeters.
3 turns is 0.4?
Yeah.
How many, so forgive me for the math here, but how many turns with an FME is 1 millimeter? I remember with MSE type 2, it was roughly 7, right?
Yeah, I think it would be 8. Yeah.
Okay, so we're still in that ballpark.
Still in
and is
that
it the
ballpark.
same with custom MARPE? Is it roughly 7 or 8
I
turns per
think
millimeter?
6 turns is 1 millimeter.
Oh, 6 turns.
Right now, this burst, and we also need to give clear instructions to our patients. So a lot of times, even though that may have worked for Dr. Newaz, who is the provider himself, we kind of keep it very straightforward and simple for patient understanding and compliance.
Yeah.
So we don't tell most of our patients that because there's a lot of ability to make errors and incorrect judgments.
This is not an endorsement of the way Dr. Newaz went about it, of kind of being cavalier and determining his own path of expansion.
Yeah.
Correct. As the patient
Yeah.
and the doctor,
Yes.
I decided to be a bit cavalier. I haven't imposed my own experience
And based off
upon
of
any patient
doing-
so far, but
Hundreds of MARPEs and FMEs, it's better to keep the instructions pretty straightforward for the patient.
Understood.
Because not every patient is the same. It's better to just be overall conservative
Of course.
to turn it forward.
Of course. And I want to get back to assessing this case in a moment, but just to be devil's advocate here, you've done 98 cases. Why do we have to look at your case? I mean, we have this history of, all of these providers of all of these other appliances, and they're always talking about, oh, I did this on myself, therefore it's great. I trust it. You should trust it because I'm using it on myself or on my own children. But why
I
do
don't
we have to
consider
look at-
this to be the basis to recommend this to anybody. And I think in our particular community, we, of course, a lot of patients have publicized their own results or have had other patient advocate figures publicize their own, their results.
with FME? in
With
particular?
FME and with expansion in general, right? There exist forums and spaces that people, we can I just wanted to show my own because I think people are curious. And I obviously, I thought it was very interesting to report some of the anterior gains as a 38-year-old male. I wouldn't have ever expected that I would actually protract up to 4 millimeters.
Oh, and by the way, this is no protraction device. This is purely
Yes,
just expansion,
correct.
which is very interesting.
I'll show you a before facial photo, and then obviously looking at them right now too.
What I was getting at with that question was the data collection problem that we have in this space, where it's a lot of effort to track these sorts of changes and then to get consent to
Yes.
show case photos, because these treatments are very personal,
Yes.
and it's hard to get consent to show a case, and it's also work to get consent to show a case.
Mhm.
More emails, it's more communications, and I just think it's interesting to call attention to that and important.
Yeah.
You can't just load up on this podcast here that thousands of people might view some case that you love or some case that you think teaches an important lesson, because there's a whole consent process. So really, your case is just the easiest to get consent for,
Mhm.
and the easiest to document because you're right there.
Correct. I think, and it's certainly, it's just the novelty of it being my own that I'm sharing it. But my own experience has never been the basis for us to recommend this to anybody. It's really just our conventional knowledge. But I think it was a very valuable experience for me to go through this as a patient.
Why? By the way, why'd you do it, and how do you feel?
Yeah, I did it. I did it because I knew that obviously I was deficient in my anatomy. I think this seemed like a very sensible way to buy back a little bit of real estate. And if you looked at, and we can maybe later show or off the clock, you can embed some images of my actual nasal cavity, which I think are in maybe the repository of images that you have.
Yeah, we have that.
Where there are some, if you go to, there are some other views where you can appreciate that, I think, a little better in the coronal view.
This view?
Well, so this is a good one to show on a surface level. Yeah, something like this.
Yes, this view
will certainly show you. And there's actually a couple interesting things to point out over here.
Courtesy of Shuikai or courtesy of Dr. Newaz?
No, this is all Shuikai.
Thank you, Shuikai.
Yes.
He really is amazing at what he does.
Absolutely. So we want to show a couple very interesting things over here. One of them, we were talking about this septum avoidance thing. I was actually a really good case of having, probably a very suboptimal septum engagement problem, but having a really good clinical outcome in terms of how even the expansion was facially. Facially, I think I was pretty even. I might have gone like maybe a tiny bit more on the left than the right. But, generally speaking, I got a very, very even expansion. But you can definitely see the septal base attachment migrating leftward. If you look at the phantom image of the screw, right, that your mouse is hovering over, the left tad.
Yes.
Right?
Here.
Then you can see that it's pretty much in the base of the septum.
Oh, wow.
Right. And again, for me, it worked out beautifully. So I'm not upset about this. But you can definitely see that my right, distance from septum to right corner of the nose is a little bit greater than that of the left. Subjectively, I have very little nasal resistance on both sides of my nose. I think I have, obviously you can see how crazy deviated my septum was, Z-shaped, remained Z-shaped, but it's, I have a heck of a lot more airspace around it in composite fashion.
Is this why they call you Dr. Z?
Yeah, this might as well be. And you can see the zygos, right? So if you look at basically this, junction right here, everything from here down is swinging out.
Yeah.
Right?
Yeah. On both sides.
On both sides.
Yeah. How the heck did you end up with the screw in the vomer? Wasn't that accounted for in the planning?
Well, I think it was a matter of not pre-activating it a little bit. I accepted it on the planning. I accepted that there might be a little bit of susceptibility. Because again, I was excited about expansion. If anyone was going to get some, either, I won't call it a complication, but if anyone was going to get, things to move a little differently than expected, like I was ready for it. Like I wanted to see what would actually happen.
And our protocol has changed with patients too. Yeah.
Since this case, this is an older case.
Well, yeah, end of September, so it's been 11 months.
This was almost a year ago.
Mm-hmm.
We placed it.
Roughly what case out of 98 was this?
Maybe a little more than 20, I think. But yeah, 30-ish sounds probably appropriate.
This was in your first tranche of 30 cases. You've since done triple the number of cases.
Correct.
Okay.
But I think these are, again, very interesting things to point out. And
this is the older version that he has too.
This is a 3.5. And for me, again, all of this feels fantastic. So now if you're asking my just subjective experience, I like how it looks. I like how it feels. I am breathing extremely well through the nose. There's absolutely no issue there, regardless of environmental or sickness or whatever. I can breathe through the nose through both sides no matter what now. Like, it's just totally not a problem. I'm sure that if we measured it rhinomanometrically, I guess, let me try to say that again. If we were to use rhinomanometry to have measured my before and after, which I never got a baseline, but then we would be able to again tease out maybe some differences between the right and left, but subjectively I don't feel it. I feel no differences. I think I have enough resistance or turbulence that airflow dynamics are still, they're not only just normal, but they're much better than they were because there was just resistance. before. Now, this actually, I want to now make a tangential generalized point about nasal resistance. Nasal resistance, and again, I'm not an ENT. I don't consider myself an authority on nasal resistance. We just simply have some tools to structurally. Now that's an authority on nasal resistance, right? You know,
Dr. Rama.
Dr. Rama, right? You know, so for me, the way that I'm kind of looking at nasal resistance and my reflections as an orthodontist who does treatments to try to improve nasal resistance are this, that nasal resistance is kind of almost like a little bit of a bell curve kind of spectrum, right? You can have resistance causing some like actual anatomic resistance or a deficiency of what we call meatal space, right? Air space in the nose. There's a certain volume and assortment and shape and, you know, size and tightness of those little, you know, curves and nooks and crannies that, you know, confers nasal resistance to a person's nose. You start opening that up a little bit. Of course, you can still, you know, you still have the same structures. You still have your enlarged turbinates. You still have your deviated septum. Of course, your septum may or may not behave a little differently after expansion or migrate or whatever. But you generally have the same deviations and the same enlargements, but their impact reduces. When their impact reduces, that generally, at least up until a certain point, is a reduction in nasal resistance. But you still, with normal anatomy, you still have enough turbulence, right? So you need enough resistance to be able, for airflow coming in with a certain velocity, right, to be able to actually push through the wind tunnel, right? So try blowing a spitball out of a paper towel holder. You might have a tough time.
Yeah.
If you spit it out of a straw, then you can actually generate some force. But if you try to throw a spitball through a coffee stir, then you might have a difficult time.
Right.
Right. It's difficult to get the volume of air necessary to produce the force to expel the spitball from the end of the straw. But in a drinking straw or, you know, boba tea straw, right, you could probably do it. But then paper towel holder, you know, maybe a little difficult, but in the opposite direction.
Right.
Right. So there is such a thing as an excess of, you know, excess of nasal patency through which people can develop UARS like, you know, kind of stuff, even if you don't have really the more problematic aspects of empty nose syndrome, because not all insufficient turbulence is empty nose syndrome. Obviously, I think empty nose syndrome is a very marked variety of that, but it's not necessarily, again, nasal resistance is on a spectrum. Maybe empty nose syndrome is like a more problematic, or in some cases catastrophic side of having way too much, you know, resection of intranasal structures, way too much patency. But just somewhere inside of that is this insufficient turbulence issue.
The insufficient turbulence issue, is that something we actually see happening with patients who overexpand or patients that have a massive anatomy to begin with? Why do you bring it up?
I think I just brought it up for the sake of bringing it up. but yes, okay, we find that to achieve a point of having too much nasal patency, even some of our patients who have expanded a large amount, I expanded a large amount. My nasal cavity increased, I think, 8 to 9 millimeters. And so, you know, I had a large amount of expansion. For me, again, I have enough turbulence, like it's clinically performing well. And I don't claim to be the expert on why that is. But we have patients that might expand a lot, even more than this, and kind of be okay. It's like nasal breathing or resistance isn't their problem. Our friend and notorious patient who expanded the most, who some people will know who that is, you know, reports good nasal breathing. But we have some that, you know, are somewhere between me and that extreme case that, you know, maybe say, hey, you know, like my breathing is a little bit weird on one side or another side or something like that. And I think we can maybe attribute some of those things to maybe an excess or abundance of patency on one side or openness of the nose. We even have some that come to us originally for consultation saying like, hey, my nasal breathing isn't good. Well, we have to see if that's a problem that can be addressed by expansion or a problem where we actually need to increase turbulence somehow. And again, that's a difficult problem to fix, at least as far as I'm concerned, in the world of ear, nose, and throat procedures. But it's been the reason that I've held off on and expressed hesitation to some patients who've been interested in FME. It's like, hey, maybe we should see if there's some reorganization required of some of your intranasal structures before we think about this. Yes, you have a narrow palate. Yes, we could improve tongue space. Yes, we could even improve nasal aperture, right? Like there's different aspects to nasal resistance. One of them is the bony window of the opening in the front and the bony window in the back, parting the C to let the air into the throat. And of course, everything in between, right, in the nose. And so when we look at all these things, then we have to think, oh, all right, why is it that you're telling me that you actually have more trouble breathing through your nose? And that's like wide open, lots of black on that side, you've had 2 septoplasties and turbinate reductions. You've had this, you've had that, and, you're having a problem, right? There's a humidification problem potentially from mucosal, sort of manipulation through procedural stuff. And again, this is also not intended to, intranasal surgery is generally a good, predictable procedure. Its results are sometimes modest. Some results are sometimes remarkable. But sometimes, when we get in there and we start rotor-rooting intranasal structures a little bit, then there can be a mucosal response problem, right? These are living tissues that sort of expand and constrict and secrete mucus and, give off different, kinds of, moistures and intake moisture, this and that, whatever. I don't even claim to understand even how all of that works. I just know that it's a thing. And so when we're looking at that whole system, then we have to think about, okay, what is it about, why have some patients told me that when I actually put a tissue and block my one nostril, then I can breathe through both sides better? Or it feels like I can breathe through both sides better if I just add a little bit of turbulence or resistance.
In other words, these things truly are individualized and every patient needs to be looked at individually to determine whether this is actually what's going to help their nasal breathing.
Oh, yeah.
And could actually make it worse if there's already excess volume and excess airflow.
Correct.
That's another concept that, our intention is to do what's best for you. Not every patient we predict. Everybody's different. Everybody's body's responding. Something that all patients need to realize. The majority of doctors all have a good intention, as well as obviously, but sometimes the best plans don't manifest the best way.
Yeah,
and that's the risk of any medical procedure.
Especially in this space, patients tend to be highly sensitive, very proprioceptive. They feel their body more than healthy patients might, and so
they might feel your body better than most patients might. I'm just playing.
I'm a married man.
yeah, but let it be known that Ronnie is a married man. A very handsome one, but very married.
Thank you.
With kids.
Definitely sizable maxilla. Definitely sufficient in the maxillary bone area.
Oh, yeah.
So back to this coronal slice. Help us orient ourselves as to where we are in the Z dimension on this slice in terms of how deep we are in the skull, because I think a lot of people wonder about FME and the posterior. It's almost a cliche, right?
Yeah.
Oh, my FME, better for posterior expansion, my custom MARPE, very anterior. What does this tell us about how FME affects the posterior of the nasal cavity?
Fantastic. Well, this is a slice that I would probably consider more or less mid-nasal, maybe slightly posterior of center, where we're at the level of the first molar.
The teeth help us orient ourselves
The
here.
teeth do help us orient ourselves to some degree. So we're at the level of the first molar here, where we can see what's happening.
So roughly right here.
Yeah, correct.
Mm-hmm.
Yep,
We're not looking at the opening.
correct. Now let's scroll through some of these other images. I think the one that was right before this, which was the 3D volume rendering view. Yeah. So let's talk about some of the changes that we're seeing here. I want to call back one of the things that I had mentioned towards the beginning of the podcast about my nasal bone. And you can see how it kind of deflects down to the right.
Here.
Okay. Yes. Well, that central structure.
This.
Yes. Correct. Right. So you see how it kind of almost swings that way?
Toward the right ear.
Towards the right.
Yep.
Okay. And you can also see qualitatively, right? So the nasal aperture is opening. That's the visible opening of the bony window of the nose anteriorly. You can also see that the adjacent, zygos and everything are both coming out. And you can, you can of course see what's happening at the level of the teeth and lower midface. So you can see that there are changes happening in the upper midface, right? So, superior nasal resistance undoubtedly has improved as a result of that kind of skeletal movement. This kind of skeletal movement is totally unique to bone anchored expansion. Okay. I'm not going
to segmental LeFort jaw surgeries.
Absolutely. When patients might benefit either functionally or aesthetically from these changes, we usually will say expansion is a very good thing to do first. And then now you also have a better developed midface to tolerate actually a more aggressive advancement, if that's what one needs for their airway, right? Of course. And even for aesthetics optimization, at least having the cheekbones kind of out a little bit. And of course, if there's a lot of symmetry issue there, that there are ways to deal with that. But at least getting them more well developed makes for these, like there are just so many people with, this sort of suborbital and zygo deficiency that are getting big advancements. So we just don't think that looks very good.
Yeah, they call that dog maxing.
Yeah, you can see
Dog
that.
maxing.
Looks like a dog's snout. The midface is left behind and then the lower third gets slammed forward.
So
Correct.
aesthetically, this looks, in our opinion, better when you combine it with jaw surgery.
When you combine it with
What the
And
doc
also nasal breathing from even someone that is could possibly be better as well.
Sure. Yeah.
Aesthetically, dentally, I like this way because then I can design the smile to fit the buccal corridor better as well.
So, Dr. Gunson would refute that expansion prior to jaw surgery is mostly appropriate only when there's an arch length deficiency. In other words, when there's dental crowding that manifests as crooked teeth or as flared teeth that are pushed to the perimeter of the bone and coming out of the bone, and that segmental LeForts can't create arch length because that's sort of this reverse Pac-Man type of expansion. And so MARPEs are best in order to create more room for the teeth. Otherwise, segmental LeFort really is more controllable, it's more predictable, maybe more aesthetic, faster. Let me just opine here and editorialize for a second. I think that segmental LeFort does not do for nasal breathing what this can do for nasal breathing. And I think that what we see on the superior here is really why.
Yeah.
Because segmental LeFort cannot expand the superior part of the nose like this. And so where do you stand on that point that Dr. Gunson makes, that really MARPEs are only really appropriate prior to jaw surgery as opposed to a segmental LeFort when there's an arch length deficiency?
Yeah, great question. I mean, listen, I have so much respect for that man that I'm not here to actually, I think what he said is correct in many ways. Of course, I would consider in the scope of what you've just editorialized that it's perhaps a limited way of looking at expansion and the appropriateness of expansion relative to jaw surgery, right? So, obviously that's, I think for nasal resistance purposes, for upper midfacial, I think these are things that haven't been studied so well. And I think that obviously once we get to the point where we're academically, properly, rigorously studying these things, studying aesthetic outcomes, patient satisfaction, this, that, whatever, I think we'll have more basis to, with authority, opine or editorialize the way that you and I have about this subject. So I just think that there's room for a little more inclusion, perhaps, even though the generalities, I think, of what Dr. Gunson and probably really most very good surgeons, they also are now met, and I feel for them because they're now met with a lot of really difficult to put back together cases. And so I can understand being in the surgeon's driver's seat and seeing that, hey, like we have, a transverse discrepancy that's difficult to manage. We have maybe certain aesthetic considerations that are difficult to manage, and so forth, because maybe somebody's really expanded a lot this way or that way. Maybe, and maybe some problems are from overexpansion. Maybe some problems are from asymmetric expansion. Maybe some problems come from, running out of room with trying to widen the lower to match the upper, and so forth. And again, these problems all have solutions. It's just a question of needing more treatments, needing more, perhaps a little bit unconventional or exotic procedures, or perhaps time or money intensive procedures to, ameliorate those types of difficulties or concerns. But
SFOT, IMDO, MSDO.
Exactly. There you go. Yeah, exactly. Exactly correct. Right. On an acronym cocktail of exotic procedures. Right. So that's but that's where we're at, is that, this is a new frontier. There are going to be difficulties. And yes, I think they're patients, of course, very educated about these things, presenting to surgeons with complex orthodontic expansion types of histories, maybe prior jaw surgery, histories and these kind of things. These are difficult things to put back together sometimes. So we're all being forced to kind of reflect and expound on things that we didn't necessarily used to have to as a profession. So I think like all of our understanding is going to continue to evolve on this, and our own individual tolerances as providers to like or not like certain things or sequences or workflows or patterns are going to change. So that's kind of what I predict is going to happen, especially with the surgical community, because I still have surgeons that tell me that, they think that, most of the consensus amongst surgeons is that this type of expansion is not possible. And all you have to do is show them a case or two to get them to say, okay, you know what? Maybe it is possible. So now we need to kind of think about how this fits into our workflow. Right. It's not their fault. I'm not trying to say this in a negative way, but it's evolving.
Opinions are evolving. I mean, something we see 5 years ago, we're doing a completely different thing now.
Yeah. Yeah. Well, I would consider Dr. Gunson's view an evolved view that already takes into account that this is possible.
Yes.
It's just
his in particular, yes.
His is a very targeted criticism.
Yes.
And it really gets to Dr. Jaffari's wheelhouse, which I think what he really doesn't like about the MARPEs is when there's too much bone for not enough teeth.
Absolutely.
He doesn't like the way that looks.
Yeah.
And I don't like the way that looks. You get these big kind of square arches as opposed to a more,
totally.
A more arched arch.
Yeah.
And it's not pretty.
Correct.
Even after a Gunson jaw surgery, an overexpanded palate from a MARPE looks a little off.
Absolutely.
But there's solutions to that too. You make the teeth look bigger.
Yep.
And I mean, I think even what we've seen is going slower with the MARPE. I definitely like that. I think aesthetically, for me, and this is my opinion, the FME, the way the expansion looks, is a little bit nicer, for lack of better words, than the MARPE sometimes.
How so?
It just looks softer, and I feel like as an aesthetic dentist, I can manage the smile better.
Is that due to its more posterior nature?
Possibly, but I just like the way it looks better than the MARPE.
Well,
Dr.
and let
Zink,
me
do you
just
have it?
quickly address some of the generalities of this surgical conversation too, and then I'll get to that in a second. But the generalities and why Dr. Gunson and similar-minded surgeons who acknowledge the possibility of expansion and why that's correct often is they can do it instantly, they can do it differentially, anterior posteriorly. They can do it in a way that is, they can get pretty significant amount. But of course, now we're dealing with, well, where are those changes going and how clinically significant is that? Maybe for some people, the nasal gains that you will make from expanding the inferior 1/3 of the nose and the nasal base and the nasal cavity, below your LeFort line, right? If you have your LeFort cut line,
Right about
your
here.
LeFort osteotomy. Correct. Yeah, maybe a little higher than that.
A little
'cause you can
higher.
literally see the
Although
canine
sometimes
root.
they're subspinal, right? I mean, sometimes they're lower. Right?
Correct. But you can literally see how where your mouse is, it would literally be cutting through the canine root. So that's a benchmark point for a lot of surgeons because it's the tallest root in the...
So you're referencing this point here? It's above here?
Yes, correct.
It's got to be up
So
here.
it's got to be up there. And then they'll usually kind of cut laterally down and out, right? Exactly.
Like
Right?
that.
So basically, changes only occur below that line. So for some people, maybe that amounts to a clinically significant and appropriate and sufficient amount of improvement with nasal resistance. So I don't tell patients like, oh, you're not going to get nasal breathing improvement with the segmental LeFort. No, you probably will. And maybe you're not getting all this upper nasal and upper midfacial expansion. And maybe that's okay for most patients. But for some patients, maybe we need kind of like a more wholesome style of nasal skeletal expansion, nasal wall lateralization, right? All of that kind of stuff. I think clearly there's some anatomic significance to that. And obviously, if we now take, fluid dynamics into the equation and we're thinking about small gains going all the way up a certain structure, that results in basically cubic level gains in, nasal airflow potential. Tell me what you were reading also
The
about
high-end
Lucille's
Nasal
law.
law, as referenced by Dr. Reliance.
Yes.
Basically, the relation between rate of flow and the radius of the tube. As you increase the radius of the tube, the resistance exponentially decreases.
It's not linear, it's exponential.
Correct.
And what's that law called?
Hagan-Kusal law.
And what's that book?
This is Dr. Rama's Shut Up and Sleep.
Huh.
It's actually a really nice, interesting, quick little read. Very manageable, digestible.
It's not overcomplicated. It shows the importance of nasal breathing.
Yeah, no doubt. And from where I'm standing as a patient advocate in this space, I get confronted by patients who say, I can't breathe through my nose. What should I do about it? Should I do a MARPE? Should I do a jaw surgery? I really, really can't breathe through my nose. And the attitude that I take is, because I've seen so many patients do a jaw surgery and come back and say, I'm still not breathing well through my nose. And granted, those aren't Dr. Gunson jaw surgeries necessarily. And as Dr. Gunson would say, chocolate cake is not the same as chocolate cake. A jaw surgery is not always the same as a jaw. It's not a commodity. It's different under every surgeon, right? But a lot of the people that I talk to are people that have already had jaw surgery and still can't breathe through their nose. And so I don't really think of these things in terms of like, what does the data say necessarily? I think of it as, how do we make sure we don't leave anything on the table?
I mean, even last week, we delivered 2 FMEs on patients that had jaw surgery and reported the same thing.
It's very common. I would even go as far as to say it's 20% of the people that I talk to. They're trying to figure out how they can get to breathe through their nose, even though they've had a jaw surgery.
That's
already.
a pretty significant cohort. If it's your, of course, if it's, the people that you've consulted with, 20% of them is a significant cohort of jaw improvement seeking kinds of individuals.
It's a lot
to
of people.
report.
There's a lot of interest in this question of can we do MARPE after jaw surgery?
Yeah.
And we're going to talk about
Which
that.
we do often. Yeah.
Yeah,
We did 2 last week on similar patients.
right. So as a betting man, my instinct is, okay, well, since it's harder to do MARPE after jaw surgery, MARPE is already hard.
Yeah.
To add the variable of the LeFort cuts, and maybe you'll tell us what the complications and the risks of doing MARPE after jaw surgery actually are. But my attitude is basically, what do you have to lose besides a little bit of time and a little bit of money? Okay, it's a lot of money and it's a lot of time in the big picture, right? But like, relatively speaking, if you're in this to solve your breathing problems, you're more likely to get all possible potential nasal gains by doing the MARPE before the jaw surgery. Is that fair, or am I misguided here?
Yeah, I think, and again, it comes down to the global analysis. Like, I mean, clearly we think about these things. So we're a good place, I think, for a lot of these patients to start. If they I always tell people, like, just for the informational guidance, like, don't get intimidated by a consultation. We send people for jaw surgery consultations. I always tell them, like, this is just information. Go digest it. Go get the information and go digest it. So similarly, we can give a lot of these individuals really kind of well-rounded information about their anatomy and where they stand with respect to this stuff. And so, so again, even though it's individualized, I think that, as a betting man, right, we're saying that, hey, we may have opportunity to get therapeutic value with lesser risk, to do this first. That may then, that doesn't preclude us from doing jaw surgery later. So why wouldn't you do that if you're most patients who might be an otherwise appropriate candidate for expansion? You don't necessarily have to choose. And I would even weigh more heavily on expansion first if there's a chance that expansion may be enough to then circumvent the need for surgery. Of
course.
Obviously, then that depends on, objectives and outcomes and, original sleep diagnosis and other things like that. And that's why more often than we did maybe 3 years ago, we're telling patients, hey, what might help us make a better decision here is if you go ahead and get a baseline sleep test.
Mm-hmm.
Right. So if you get a baseline sleep test and we can see, okay, hey, there's maybe a more significant apnea component, or there's more significant sleep metrics even without apnea, but we've got some pretty strong upper airway resistance, sort of signals on your sleep study. And we're seeing that is also kind of, coinciding with or correlating well with facial disharmony, skeletal disharmony, chin in the throat kind of look. And so maybe you don't have apnea, but you certainly could benefit both functionally and aesthetically by having, forward features in the jaw complex. Great. Let's try to optimize you for surgery. And because we're optimizing for surgery, then maybe this is a good workflow where you talk to the surgeon today and you kind of see what they say about, being able to do segmental stuff. We are encountering, of course, that some, very well-known surgeons are perhaps reluctant when patients show up with pretty well-coordinating bite to do a segmental LeFort. If that's the case, well, then it might be a good idea for us to do expansion first. Just literally align that good bite in a wider complex and then present it back to the surgeon later, right? But if a surgeon is willing to or finds it appropriate to do a 3-piece LeFort with expansion and rotation or whatever else the patient might need, then there's a real question on the table. Like, do you do surgery first and really avoid the hassle and the cost and the, putting back together and the orthodontic risk associated with expansion? I mean, absolutely, especially if the patient's, certain aspects of their clinical presentation don't scream like, oh my gosh, I need this kind of super high quality nasal expansion.
Yeah. Patients that aren't particularly suffering from really horrible nasal breathing might not need to go the extra mile to do the MARPE.
Correct.
Or patients that already have an aesthetic midface.
Absolutely.
But it still may be wiser to consult with us first before engaging maybe double jaw surgery.
Yeah.
And, I think some of the benefits of working with us is we have both of our eyes looking at a lot of our cases. and they were very good quarterbacks, similar to, you have a good understanding of a lot of the doctors and surgeons in our space. We also have a good understanding of what each surgeon's brings to the table too. So we kind of know, just like you may recommend one certain surgeon or another, we can do the same thing, right? Whether it's internationally or even nationally. And then also that comes with other adjunct like myofunctional therapists and, PRI, PTs, things like that as well.
Yeah, of course. Would you like to look at any more features of your case? I have a big question for you, but is there anything more that you want to point out on your case before we maybe shift gears?
Why don't let's scroll through one or two other images. This is a good one. This is a great one where you can see anterior movement, and you can also see movement of those, nasal structures off of the septum, which in this frame looks pretty neutral, right? So, but yeah, and then you can see again.
Look at the left side.
Yeah, I mean, and my weight profile is about the same between these two images. I weighed about the same amount, so, but look at, so if you're just looking back here, actually, when I got more anterior movement, things actually and we can see what's happening skeletally with the zygos, but some of the soft tissue, right, is actually like kind of stretching out, being pushed out so that it's not bunching in with the backward, right? It's being stretched and pulled out. And
Kind
this
of like
is
intake breathing, but permanently.
Yeah, and you can even see like right there in front of those, well, if you go all the way to the outermost point of the soft tissue on the side.
The soft tissue where?
Like basically just the outer edge of my face.
Okay. For example, here.
And go further back, back. There you go. Right about there. You can see that's where it's the widest, right? And you can see that's where, right, it comes off of your mouth and it goes in, right? Because again, the whole facial anterior skeletal structures are pushed out. So it's like sort of lengthening and, kind of pulling the soft tissue forward a little bit. Meaning, despite me not having really lost any substantial amount of weight, that's kind of compressed a little bit in here because, it's the zygos are coming out here, but like the facial soft tissue is being pulled out, right? So that's.
And why are you calling attention to this as an aesthetic benefit? It's just a observation. I don't necessarily, want to, I guess, assign a.
Well, I mean, we could say it's kind of like intake, like going back to the intake breathing. What is intake breathing? But the magnets pull, so when you're moving everything forward, the skin gets more taut.
Which is more in the front. Yeah, if you look at the front of the face, like what's happening with the soft tissue, it's very much the intake breathing type of effect, right? Like you're either pulling your nostrils apart or you're doing that to the soft tissue. Like how the soft tissue of the anterior part of the face is behaving as a result of expansion.
And from a cosmetic point of view, isn't this basically what they do with like a facelift? Don't they kind of, they try to drape the skin more taut or pull it more taut? And
I mean, aesthetically, I would say that our patients, for the most part, aesthetically look better. Now that could be better sleeping, better oxygenation, but basically that tautness, tightness, the way the maxilla and the zygos, the cheeks, the mandible, everything kind of looks really harmonious with this expansion profile.
Does this have an effect potentially on the chubby cheek syndrome that a lot of patients present with that they want to address?
I think, this could be, this is framework improvement supporting that problem, yes.
And same thing, when you go to an ENT, they're doing a lot of soft tissue manipulation. We're saying do the hard tissue first, and then if you want to go back and do soft tissue, now the ENT has more space, you're changing the foundational hard tissue. Then if you still need soft tissue, you still can go back and do deviated septum, turbinate reduction, something like that.
And then now, Ronnie, look at the posterior aspect of the maxillary sinus. All right. And then, so yeah,
Here.
so look at that, right? So basically you can see that there's some anterior migration over there. This is very posterior part of the maxilla. Of course, and then posterior to that, those are the pterygoid plates, right? So posterior to that are the pterygoid plates. Now you can see in my case, actually, the pterygoid plates didn't actually move much. In some cases,
These are the pterygoid plates here?
Yes. So in some cases, right, where we don't actually get full disjunction, the pterygoid plates kind of flex out a little bit. You can see actually not as much of that's happening. I think for whatever reason, maybe because of all those functional things that I was doing, I might have been able to accelerate or induce some more separation at pterygoid maxilla. I'm not going to claim to also understand or present why that happened, but the fact that it did happen, now you can see how the skeletal structures behave, right? That you can basically see that at least the maxilla is coming out as if I got pterygomaxillary disjunction.
Right.
Of course, pterygomaxillary disarticulation is a common feature of high quality skeletal expansion. In my case, well, it was a point where we got, a significant protraction forward because of that. And I think that we see with similar people who've gotten similar amounts of expansion, they tend to have similar patterns. Like, I think as a community now, we can kind of say, like, hey, it's maybe safe to say that if you expanded at least a certain amount, we don't see this in early, very conservative expansions, but in maybe a little more advanced expansions like this.
This is what?
Some protraction.
What are you calling this? 9 millimeters?
Yes.
Okay, 9. This is let's call it a 9 millimeter expansion, although when you put a number to an expansion, what does that even really mean, right? Because not every turn translates to an actual movement of anything. Sometimes it's just buildup of energy.
Exactly. Even though in my case, it was pretty damn close to like what the activation of the device is and what the skeletal movement.
Because as soon as you started turning, you started seeing movement.
Well, pretty early into it. I think I was like 9 or 10 turns where I started to kind of, be able to slide like, a little something.
Sure.
Between.
So let's call this 8 to 9 millimeters of expansion.
Let's call it 8 to 9 millimeters, for simplicity's sake. So you can see my pterygoid plates aren't really moving too much over here. Now there's another multiplanar view GIF. This one, I believe. Yeah. Now let's focus on that top left corner of the image. So this is also very posterior, right? So this is the pterygoid plates. So you can see that something's happening at the pterygoid plates. They're just kind of flexing out just the tiniest bit. But again, nothing too crazy going on there, right? You can see a little nasal cycle type of activity there too. Again, the pterygoid plates themselves, it's not like I got some massive migration over there. But if you're looking to see if basically this expansion affected posterior structures, there's your, you can kind of see the pterygoid plates flexing out a little bit, right? Obviously, we know that just anterior to that, there's significant movement. Mm-hmm. But even there's some movement, right?
Yeah. Yeah, that's fantastic. Anything more you'd like to point out?
No, I think that's pretty good for now. Yeah.
When we get back, I want to ask you about what your plan is for the lower.
Okay.
All right, we're back from our 5-minute break. So, Dr. Z, what are you going to do about the lower in this case? We can see here that the uppers are, it's not quite a Brody bite. There's still contact there. Tell us, what's it like to chew with an expansion this big? And how are you going to get the bite back together?
Great question. For me, I've learned to, I've learned and adapted to chew more or less normally with this bite. Obviously, it's considerably off. So clearly the lower does need quite a bit of, dental expansion or uprighting. And I think it's actually within the realm of being able to do that, especially if we can maybe cheat and tuck in the uppers just that tiniest little bit. So that's certainly one pathway that we could use. Like, I'm still within the realm of basically orthodontic arch coordination.
Without SFOT?
Without SFOT, I believe that I could do it. Sure, would it be more excellent if I did it? Because, if we maybe reference some of the prior, like the 3D rendering from the front, you can see I kind of have that longer, narrower type of bone structure where the roots are sitting in pretty thin bone anteriorly. So I could maybe use some grafting, I guess, to make things very, very excellent. I don't think I particularly need that to be able to align, routinely.
Can we
Or
see
I
that?
could always,
Can we see that here?
You can kind of see that there. So you kind of see the outline of the roots. There's kind of some washboarding, I guess you could say. What is washboarding is basically when you can see the contours of all those roots. So being able to, just put a little bit of extra bulk around some of that bone, I think would be a decent, decent intervention, but perhaps not a totally necessary one. It would be great, and we work with best in class to do that kind of work, I could call up Dr. Mandelaris in Chicago, and who's an extremely well-rounded. It would really astonish someone to know that being a periodontist, he knows as much as he does about overall craniofacial anatomy, structure, sleep disordered breathing, nasal, airway, all these kind of things, right? Cephalometrics. So I'm very impressed with his knowledge base. But, I think that he would tell you that phenotypically I have the type of, jaw that often benefits from SFOT style work. So I may not elect to do it, but I'm certainly actually a really good candidate for it. And that would be maybe a surefire, easy way for me to put this back together, maybe perhaps relatively quickly. And also safely, right? And also because my expansion has been so gradual, so slow, or at least the overall start to finish time has been so long. Of course, we have some, difficult task of uprighting, roots in the incisor area, common post-MARPE alignment problem, which would also further be facilitated with SFOT. Am I going to do it? I don't think so, but am I classically a good candidate for it? Absolutely.
So are you just basically eyeing a purely orthodontic solution to this bite?
Well, I think orthodontics would be at least my default approach, although I have spoken to my friend Dr. Movahed, Reza Movahed in St. Louis, who, I think I'd be, again, just with the curiosity angle of my treatment. Obviously, MSDO is kind of like an enigma in a way, but, being able to do, a nice anchored distractor, right? So he's built, kind of his own sort of distractor design where there are some TADs on the lingual. You have just really good anchorage. You have a little bit better control to be able to distract the mandible. So I might call him up and ask him, hey, do you need me to create any room for myself between the central incisors to facilitate a little bit of a cut down the middle? Maybe we can expand that out. I think there's basis to suggest that maybe slight increases in, bigonial width and all those kind of things, which of course you can get more predictably perhaps with surgical mandibular widening, which is just to make those two procedures distinct. You can widen the mandible through distraction, through putting an expander and making a cut and distracting it out, but you don't necessarily have as much control of the what we call the proximal segments of the mandible, or the ramus and the condyle complex. So, you rely on them to rotate and still be able to situate well within their existing sockets, right? Mm-hmm. And I like my prospects of that, especially now with some decompression that I gained from expansion and a protractive movement of my maxilla. I think I can tolerate that. Not everybody can tolerate that. I think you have to look, mediolaterally, and you also have to look anterior posteriorly to see if maybe that anticipated, geometrical kind of reconfiguration of the condyle would be able to situate in your fossa. But so I'm gonna do that. But if one is again kind of going for double jaw surgery and might need a little bit of mandibular widening at the time of surgery, that's a way that you can control you can control the placement of the condyle ramus complex and uncouple that from whatever you're doing with the body, whether you're advancing it, rotating it, or in some cases splitting it down the middle to be able to achieve a little bit of width. Mm-hmm. But in my case, I think I'm gonna holler at my friend Dr. Movahed to to look at, see if I'm a decent candidate for that.
Is that a decision that you just made right now? Right now, as you thought?
I've been contemplating it. I've told some people about this too.
We've talked about it before.
Yeah.
You and I have talked about it before as well.
Correct.
Yeah.
But again, I'm just being really lazy about starting the next stage of this journey. Obviously, we're running around trying to, keep our heads above water right now. So, but yes, when I do get back, when I get, to putting this back together, that's certainly one of the things I'm going to look at.
You're not worried about this then?
No.
You're not, and
I'm not the least bit worried about this.
Yeah,
this is nothing.
Lots of ways up this mountain. Dr. Jaffari?
I'm a little bit more conservative, I'd say, because if when we look at patients, going back to the beginning of the conversation, what is success, right? For most patients, it's therapeutic benefit. So what's the amount of expansion needed for therapeutic benefit? Once again, Dr. Newaz is his own patient, right? So my patient, his paper, but he wanted to kind of push the envelope, right? And then, could, a procedure with Dr. Mendelaris or Movahead make sense? He has that option because once again, they're our colleagues. But on the patient facing, what's the therapeutic benefit, right? And is expansion to that level necessary? And if not, then you don't expand or need to expand those, don't do it, right? Because then, right? So that's kind of my perspective is, let's do what's necessary to get benefit, because then it allows for avoidance of some of these more complicated procedures, more expensive procedures.
Right. And you mentioned earlier that law from Dr. Rama's book about the exponential increase in, well, maybe you could recite that, but the take home from that was that maybe you don't need that much expansion to get the therapeutic benefit that you're looking for. And I think that...
Yeah, and when you're factoring in multiple variables, the compounded effect of those variables can be greater too, right? So, let's just say you're expanding the palate, the floor of the nose. Now, let's say you were to now have more space for the tongue and do myofunctional therapy. There's the cumulative effect of all these things could be very larger than the sum of the parts themselves.
So why did you go this far?
I wouldn't really call it far. I mean, in my case, I now have what I would consider a more normal maxilla. I mean, I was so deficient before, and it was crippling to be that deficient, so I think it was, this was very helpful. I really see this as restoration towards normal. And of course, I was perhaps a bit more unafraid than, standard, because it was myself. I've got people around me that can help me fix it if something goes wrong. And I thought philosophically it would be maybe good for me to experience maybe a couple things going wrong too, just to be on that side of the chair. It's never the same on the other side of the chair. Right. Like if you're the provider, there's a certain level of still distance and separation you have from experiencing an event or a complication or something that maybe makes you better able to understand and empathize with your patients and stuff like that. So part of me was just ready for that. So I unapologetically expanded myself. I'm not even necessarily done.
You might continue to expand?
I might.
Yeah. I think that another key point here, obviously a lot of the JawHacks audience are younger. They're financially not in a place where they can sort of venture off into the woods, so to speak, on a treatment and not really know what the plan is going to be. And you have the dry powder to do a resin overhead mandibular expansion or a $30,000 SFOT with Dr. Mendelaris, but a patient who is really, bending over backwards to come up with the money to do expensive MARPE treatment in the first place, that doubles the cost. I mean, I don't know what Dr. Movahead's treatment costs, but it's got to be 20 to 40K, I'm guessing. I know what Dr. Mandelaris' 4-quadrant SFOT costs. That's $30K. What I'm saying is you need dry powder to be able to go into battle with these things.
Mm-hmm.
And I think a lot of people, a lot of patients I have seen doing MARPEs with various providers kind of end up getting caught off guard by the need to do an SFOT.
Now, is dry powder another word for money?
Dry powder?
Yeah.
Just like
This is the first time I'm
ammunition.
hearing.
Ammunition.
Oh,
That's
ammunition.
that's not wet.
Oh.
You can't shoot wet.
Oh, okay.
Gunpowder.
All right, that makes sense.
Yeah.
I was about to say, I mean,
Yeah.
all right.
Yeah, dry finances.
Dry finance.
That's a New England reference.
That
to
sounds
colonial.
very, us here in the South, all powder's just wet all the time.
100% humidity
Right.
year-round. Indeed.
Yeah.
Indeed. Yeah. So, do you think your case? This was sort of what you were saying earlier about how what you do on yourself is not necessarily you advocating that
No.
everyone should do this.
Absolutely not. I if I'm going to push boundaries on anybody, it'll be me.
Yeah. Yeah.
At least meaning,
I mean,
I'll rephrase that. Obviously, we have pushed boundaries before, but I'm unafraid to push boundaries in myself because I'm again for the reason I mentioned. But that's just, I think it's more just intellectual curiosity.
Well, you guys just so happen to be the guys that people are going to go to when they want to push boundaries, because you guys are probably the most prominent orthodontists on the internet when it comes to airway stuff and jaw hacking stuff. And so inevitably the intellectually curious types who have, what should we call them, alternate philosophies when it comes to what jaw hacking is all about, and people who may have an attitude of, I want to try to recreate a genetically optimal phenotype, they're going to end up in your office, right? And so...
But we're confident, we're confident with pushing the boundaries and dealing with the ramifications that come with.
How does that go? Patient by patient, based on what they say they want?
Not necessarily. So, and I want to put a little bit of clarification around this concept of pushing boundaries. We have no intention to be reckless. Okay, something has to make fundamental sense, and there have to be fundamentally sound procedures or ways that we can get ourselves to a comfortable finish line. Sometimes we see those existing in ways that other providers don't. But again, we don't need to step outside of the realm of fundamentals to achieve certain things sometimes. We just may need to think about, okay, well, what are the considerations and the ramifications and the, possible cocktail of follow-up procedures or, whatever that we're going to have to do if we do X, Y, Z. And if you want to customize and tailor a treatment plan that perhaps, you haven't gotten validation from other providers or whatever, we'll usually engage in that little bit of a dance with you. That being said, I think one of the criticisms about me personally, has been that, Dr. Newaz will kind of do whatever I ask him I want to do, right? Or whatever. And I think there's some merit to that. I think we're starting to reel things in a little bit. I think how we are today is, again, it's a little different than 3-5 years ago.
Well, everything is different than it was 3 to 5 years ago.
Right. But that being said, we still like to be in that position to help hear out people on, and kind of democratize this process a little bit, right? This is an age where people are very educated about their own situations. They're obviously their own expert, if that makes sense, meaning they think about, all the things that they might need for themselves, and maybe some intuition comes into play. Sometimes our job is to help sift out what is guided and misguided about those feelings and thoughts and direction. And I think we're doing, a decent job of that. And it's a difficult position to navigate. I mean, I would challenge anybody to live our lives for a day or a week. Trying to, it's difficult being on the, kind of trying to be on the leading edge of a space where you do have to navigate fundamentals and also, perhaps rejecting certain establishment norms and principles. There is a fine line there, and we don't, it's a difficult place to position yourself. But we've chosen to position ourselves there because we see a need for advancement in this field that comes with the territory. So yes, I like to help, generate custom treatment plans and things like that with our patients. We perhaps allow our patients to participate a little bit more than I would say the average provider in contemplating how that treatment design and workflow looks like. But at the same time, again, we have a job. Our primary, thing is to try our best to do no harm and, and to always try to have a solution. I think anyone who works with us knows that, we acknowledge when we're not perfect, and we always try to help someone get out of a situation that perhaps, is a challenging one.
How do you know when what a patient is asking for is unreasonable or a situation that you can't get out of the woods on? Is that just a matter of experience from your 6 years of doing skeletal
Experience
expansion?
and fundamentals. There are certain things that just fundamentally cannot occur, right? The bone housing the teeth is only so wide. Things you can do to augment that bone can only go so far. That's just an example. But we have to kind of think about those things, like, and not necessarily try to bank on some of those fundamental assumptions being false, so we have to at least use the framework of fundamentals and establish peer-reviewed science, and then couple that with, our willingness to tread, the waters of a little bit unexplored territory when it comes to some of this.
I mean, I'd say when we were in grad school, I can speak about myself, when obviously the dental Hippocratic oath, do no harm and try to do what's best for the patient. We have a perspective as a provider, and what I've seen with a lot of our airway patients, very, very, very intelligent. They know their body better than anybody. And so we actually listen to our patients because their perspective is very, very important. And they've thought about their situation, their condition so much to a very high level that getting their feedback and having the part of the brain trust, just like we were talking about the lab before, having the patient part of that, if they know what they're talking about and they've done the research on themselves, they've done a lot of the homework, watched a lot of your videos, things like that. I think it's wise to sit down with them to get their perspective rather than being like, oh, we're the doctors, you have to trust us. Because there is a tremendous amount of value with our patients. The ideas that our patients have to the way we implement it, and you see this, these same types of patients are very knowledgeable about the space.
Oh, I learn a lot from the clients that I bump into.
Oh, yeah.
And so same
100%.
thing, we don't discount that. And I think that that's also a differentiating factor where we don't just write off our patient and be like, oh, they don't know what they're talking about. No, we actually is there a perspective that we're not seeing that they may be seeing?
Mm-hmm. Mm-hmm. I would even go as far as to say that I think there's probably a perception that, for example, with me and with JawHacks, maybe people get the sense that, oh, I'm going off and I'm somehow studying and reading literature alone off in an ivory tower somewhere about these procedures and about, papers that have been published and data on the efficacy of certain things, and that's how I'm learning about these procedures and this stuff, but actually it's just the fact that I'm talking to other patients all the time about their real-time experience with procedures, with doctors. That's where I learn from.
Mhm.
And so it's, the patients it's not a one-way street. It's a feedback loop with the clients. In my case, they're not patients of mine, they're clients of mine because it's a consulting relationship. So I get that, I mean, listening to clients is what I do. That's like my whole model.
Mhm.
Where does informed consent come into play when you have a patient, in your case, who has an intuition? And for example, just to ground this, right? Like expanding to the point that the soft palate gets pulled taut and actually pulls off of the back of the pharyngeal airway. Like in your case, you expanded to the point that you got this 3 to 4 millimeter anteriorization of the hard palate that brought the soft palate with it. People traditionally would think that that's only possible with the LeFort jaw surgery. The fact that you pushed the boundary a little bit means that you're probably going to avoid a LeFort jaw surgery because you're not having soft palatal collapse anymore. We saw that on the scan. There's reasons that boundaries are pushed, but how does informed consent come in where you have to say to a patient, hey, look, if we go that far, it might mean 2 years of orthodontics instead of 1, or even 3 instead of 18 months. Or maybe you need this auxiliary $20,000 to $30,000 periodontal procedure or a maxillofacial mandibular surgery to get you your bite back. Is that a conversation that you'll have with a patient like that?
These are very common staples of our conversations. It's really what our consults consist of for the most part. So it's, anatomy review, diagnosis, sequential treatment plan, contemplation or presentation, and discussion about some of these things. What do you think?
Yeah, I mean, I think that this is a newer space. And so you have to go over all the risks, all the benefits, all the possible complications, all the things that we were saying before. Not everybody's bodies respond and react the same way. So 90 cases we've done, let's say 90 of them responded the way we thought, some of them didn't. So what's the next stage of dealing with that issue? That has to be part of the initial conversation. That's something that we hope to not have that path happen, but that's something we have to address before we start. There's a risk with any medical or dental procedure, right? With any surgery, there's a risk, and so the patient has to understand that, right? Once again, we're all trying to do what's best. However, there are complications at times. Yeah. So the patient needs to understand: does SFOT make sense, or the Dr. Moved, distraction type of stuff.
Mm-hmm. Mm-hmm. Yeah. Well, I'll be curious to see how it all comes together in a year or two from now, and what you end up doing, and whether you just end up doing an orthodontic approach, which I think is, I'm curious to see how that plays out. Speaking of not quite out there stuff, but new and mysterious stuff, I want to talk about protraction, the FME, which you guys showed on your most recent YouTube video. I think that was the first ever reveal of the FME. This is a brand new protraction device, aka face mask, created by FaceGenics via feedback from you guys. I think you guys were even involved in. Would you say you were involved in the design process?
Actually, no, for FME, no.
Okay.
No.
Okay. Let's take a look at that. Let's load that up on the screen. And then I want to hear what you guys think about the design.
But even in our first podcast, Dr. Newaz is very pro protraction, right? And so I think that definitely we see the potential of protraction. We've seen it with our patients, and now we hopefully will see with FME.
But when you have the expander itself giving you 3 to 4 millimeters of advancement, what's the need for a protraction device if that's the case? Is it just not always true that the maxilla will move like that with expansion alone? Or is it for people who want to expand less so they don't get as much, occlusal effect?
I'm growing curious about the pending data set. We're really trying to study a bit more quantitatively some of the results of the findings and the CBCTs and so forth, to see if there is a juncture and consistent sort of, maybe a little bit more predictable way of saying like, hey, you might be able to get this sort of grade of protraction through expansion alone. Most people who expand up to this number of millimeters get 1 or 2 millimeters of protraction, maybe. Yeah, we're trying to kind of see what's possible because, in my case, like once I saw this and actually measured it out, which was very recent, as I was contemplating kind of actually using the FMA myself, which I may still do, I may still not, but if I, at least this was kind of confirmation that I was correct in seeing and feeling some of the things I did during expansion, and makes me feel that I don't really need to protract. I mean, this was good enough for me, for my purposes, having my whole midface come forward of that much and be able to get mandibular decompression as a result and generate maybe a good, viable, reproducible bite in that position and have a little bit more tongue space, a little more airway, and certainly a lot more nasal volume. That's good enough for me. So if we're just speaking in terms of necessities, I don't need any protraction. But like if we're speaking in terms of, like, hey, do I want to see if this could go further? What might the possible merits be? And let me just take myself out of it real quick. If one, protracts this amount, then what would the additional merit of protraction be? And would it be worth the struggle? And I think it could be, again, if someone's pharyngeal airway is very collapsed and maybe the soft palate has a lot to do with it, and you're bringing this whole, upper jaw, midfacial complex forward in the face, you might have the potential to make some, 2 jaw surgeries into 1 jaw surgeries, thereby making the process a little bit more conservative or whatever. But you have to also think about, what planes of movement are required for that individual. Some people need advancement, some people need advancement and rotation. So those are considerations. And then, of course, the thing that we talked about with the discrepancy of the forward positioning of the lower part of the face, lower third of the face, and then maybe the middle third of the face. If the middle third of the face is very deficient, then, maybe some protraction could actually help balance out in an eventual surgical outcome or something, which still remains. It's like, why would you protract if you're going to do surgery anyways? Well, one of the reasons you might consider it is something like that, right?
Right.
Again, is it worth it? And, what does it take to get X amount of millimeters of movement? And, that's all to be determined. I can't say I have the answer to that.
Do you think your joint can handle more protraction?
My joint, probably as it stands now, maybe a tiny bit, or I'll just have a little extra overjet. I can live with some extra overjet.
Now, what did your MRI show?
Oh yeah, let's talk about that. Yeah, because I deferred that, I guess, the last time that was brought up. So basically, I was just recently at the University of Minnesota with a small group of radiologists. There were, I think, like 11 of us. They have the first sort of oral maxillofacial dedicated MRI center in the country. And it's it was a really cool experience. I did it in part to just kind of reawaken my radiology muscles a little bit. It was a very good experience, a very humbling experience, because if there's any way that you want to remind yourself that you're not that smart, you sit in a room of radiologists. They'll humble you real quick. And I needed that. I needed to kind of, feel that, like, wow, like I have so much to actually learn.
You are a radiologist,
I am.
just in case people don't know.
Correct. So I am a radiologist. Obviously, my radiology type of side of practice has been more limited to, of course, doing radiology interpretations for our patients and doing a few reads on the side here and there, but mostly on routine overruling pathology kind of stuff. Like sometimes you just need a little bit of that boost, like see some of the exotic stuff, see some of the up and coming stuff, right? And that's why I did that, because I was kind of starting to get a bit monotonous with my sort of radiology tunnel vision as an oral maxillofacial radiologist who's primarily a clinician. And I hope that one day I'm actually able to flip those things around. That's an intention of mine, to be able to primarily actually be a radiologist and then maybe a clinician on the side, or have my background clinical training inform my activities as a radiologist. But that's for later, I guess. But so at this course, we actually had the really fun experience of acquiring MRIs on each other. And so and it was a really cool group, because some of the people whose names that you see on textbooks and other things, we had the chance to all kind of sort of be there together. And it's a place where the people teaching the class are teaching the people who have written the books on the subjects. But anyways, so what Dr. Dania Tamimi told me, after we acquired, some images, and so I got scanned, and then I said, "Hey, Dania, can you come give me your sort of 2-minute elevator interpretation of my case, just to see if hey, do I have disc displacement, this, that, whatever." Because certainly in the past, and again, we can maybe show a parallel thumbnail or something later, about, like, hey, this was my starting condylar position. It's clearly posterior center in the fossa. In our view, in our sort of radiologist kind of way of looking at that, we're saying that, hey, this person has a high probability of anterior disc displacement, right? We can't see the disc on a CBCT, but you can tell on hard tissue imaging that your probability of having that is very high. And obviously, the clinical correlation for me, the clicking, this, that, whatever, is confirmation that there's something going on. And then to see how that disc then behaves when you do certain things is a separate sort of exercise and evaluation. In my case, of course, I've done this slowly and sustained enough with all this expansion and jaw reposturing kind of work, that one very, very interesting, very fascinating observation that Dr. Tamimi made when she was looking at my scan was that, hey, were you wearing a splint or something? I said, no, I wasn't wearing a splint, but I did all this expansion stuff, and I've been able to hold my jaw in a little bit more sort of down and forward position. And she was like, you can actually see that. So you can actually see the old sort of phantom outline of your old cortex, right? The posterior cortical boundary of the condyle, right? So if you have the condyle, you have the posterior cortical surface. And in all my before CBCT scans, you can see that it's intact, but it's just associated with the posterior position. And then, of course, as you come down and forward a little bit, then you can get some surface remodeling, right? Sometimes you really need surface remodeling because your external texture of that sort of cortical smooth, what should be a nice smooth eggshell kind of looking appearance of the condylar bone, you have like you can basically have, like, if you have arthritis or degeneration, then you can have some porosity there, you can have some irregularities there, you can have some choppiness there, right? And so classically, what we hope to achieve with orthotic or decompressive orthodontic kind of treatment is some surface remodeling, right? You want that to kind of smooth over. You might have lost your volume, but you want to get some, surface remodeling. So we actually saw, even though I didn't start with this super porous kind of type of appearance, I did get a little bit of deposition of bone on the posterior superior aspect of the condyle. And that is only due to the fact that I've now been able to put my jaw in a decompressed position because my maxilla is protracted enough to allow it to do so. So you could actually see the new bone.
So your condyle is healing?
Yeah, I guess you could say it's healing, and there's just that tiny little layer of surface deposition, which we could actually see in the MR.
So a lot of our patients that have TMJ issues, by expanding, they do get TMJ relief.
And that's a matter of it's better to have the condyle come forward, even if it's not in a centric relation. It's better to be slightly forward than it is to be jammed back. Is that the idea? Because when it's jammed back and you have bone on bone in the backward position, you get sort of arthritic fallout.
In generalities, yes. In terms of a nuanced discussion of the subject, of course, then you have to think about the anterior aspect of the confines of the joint space, and perhaps there's all other kinds of untoward compression in the anterior superior part of the joint.
But centered versus posterior.
Centered versus posterior. Center is better than posterior, and slightly forward of center is usually okay. Right. That's
especially
basically
given that there's an airway benefit to being there.
Yes. Correct. Of course, very anterior of center is not sustainable or stable, and nor is it probably a great proposition for dispositioning, disbehavior, and then if you're loading your joint on the articular eminence, which is that sort of slope in front of the socket, right? Then you could flatten your articular eminence, and then that affects joint range of motion and uncoupling of the bite and all that kind of stuff.
Yeah, and all of this is part of what some people call the controversy around centric relation of the joint and whether or not centric is the end all be all of joint health. It's more nuanced than that.
Much more nuanced than that.
Yeah. Well. Yeah. Thanks for sharing that. Let's take a look at the FMA. So here we have the FME. This is from your YouTube video at Airway Ortho. And we can see here in the mirror, we can see the attachment points where the FMA device is supposed to hook in. Is that right? Here and here?
Yeah.
And here we see part of the FMA device. What am I looking at here?
This is what we call the protraction wire. So this wire is 3D printed to a patient's individual arch. And on the other side of this, like on what would be the top part of the screen, there is like a little, you can almost kind of access the little expansion screw, which is the same hex as the FME, that you can use to basically make this wire wider or narrower based on how much your FME is wider or narrower.
So
just so it'll actually fit.
Wow, you go turn for turn?
That's the idea.
Yeah.
That's the idea. Now, there's some give in that, so that you don't have to be right on the money, but yeah.
What are we seeing from this side?
There you go. Yeah, you see those little arrows on the base. Yep. Those little arrows are just showing you that, when you crank the screw down this way, then you're expanding the wire.
Mm-hmm.
And then, if you zoom out to about there, now you see the middle part, the part that's sort of coming towards us on the screen, that little bar extending from the vertical bar.
This?
Yeah, correct. And then you'll see that sort of L-shaped insert.
Here.
Inside, yep. And so that's where the actual, what we call the force applicator attaches. So this wire, so imagine the back part of that wire is in the patient's mouth, right? And then coming out of the mouth is basically like the lips are resting on the sort of contracted part of the wire. Then outside of the mouth, you have this whole apparatus, right? And then you're attaching the protraction wire to the inside of that insert. I'm sorry, you're attaching the force applicator to that side of the insert. And you can kind of see how that comes together here, although you can't really see the bars too well. But that little tape measure looking thing, that black circle, you see that?
Yes.
Yeah. So that basically the base of that, where it becomes straight, pulls out. It's literally like a little tape measure. This is a very unflattering angle, but that's fine. That comes out, and that's basically, and you can kind of now see it sort of coming out a little bit from itself. And then you can see how this protraction wire sort of comes out from the back of the FME, loops around the mouth, comes out, makes this thing. And then that black circle thing, the force applicator, is attached to this little bar that's attached to the body gear, so that you can move your head up and down and that thing will kind of roll with you, right? There's like white little rollerball track looking things on the arm, the bar.
Here
right?
and here?
No, a little bit more on the curved bar.
See the white?
Oh, here.
Yeah.
Yeah. So
They
those
kinda
are
roll.
like roller bearings.
So that's for comfort?
Yeah. Essentially for comfort and flexibility to be able to move the head a little bit.
It looks like Sandra Khan's bow.
Yeah, it's got a lot in common with that, in that it has no, I mean, basically this extraoral anchorage doesn't depend on the mandible, right?
Right.
For protracting the maxilla. It just depends on having something, obviously attaching it to the thorax and abdomen, it's a pretty strong anchor. Now
You could change the force applicator too
exactly.
to a stronger. So is that 5 kilograms?
That's 2 kilograms. And they make force applicators up to like 7. I didn't F with that really.
What did this feel
but-
like?
I mean, it feels like you're pulling on your midface.
Does,
forward.
huh?
So for the moment that you're wearing it, you can actually feel it engage, and you can feel pressure here,
Mm.
where it's trying to kind of come off of those,
Why are there
areas.
so many bars down here?
So those are basically, well, this is part of what makes FMA, I think, a little bit like, I mean, again, this is a serious contraption here, right? And what you're seeing is this bar, like those vertical bars, actually, so the white base and top, they also rotate about like a sort of curved track type of thing. So that you can actually turn your head or your body and that thing will sort of move with you.
Really?
Yeah. Right. Yeah. You see that sort of curved bar? So it's actually, there's roller bearings down there too.
In here?
A little bit south of that, like just where the white thing is meeting the curved
Oh, here.
base. Yeah. Correct.
Mm-hmm.
Yep. So you can theoretically turn your body or your head and this thing still stay attached.
Would you wear this to the Florida Gators game?
I think there's a world where I would do something like that, but it would be difficult to get past security.
Yeah.
With something like that.
Although you wouldn't be totally out of place.
Yeah,
I mean, with the people wearing the gator heads and stuff,
exactly.
kind of gives a whole new meaning to the gator chomp, right?
It sure does. And good luck chomping me with that thing if you're a gator.
Right?
Right, if you're an actual alligator.
So here we can see more components.
Yeah.
What am I looking at here? These are the different force applicators?
Yes, correct.
And how do you determine which one is appropriate for a patient?
I mean, you always start small and then you kind of work your way up. I mean, I think that's at least the posture that we're going to take. We're never going to start with anything other than the lightest one. Have a patient get used to it, and then
change the vector.
How does this thing work with angulation
to
and vector?
some extent.
Let's talk about vector for a second. What's possible in terms of angle changing of the structure with this?
Well, now the one thing that this doesn't lend itself to is one-sided pulling or pulling much further up or down than the sort of planned vector protraction. And yeah, with a more rudimentary face mask system, you do have a little bit more flexibility. You do have a little bit more, sort of freedom of application. I have some patients who have made some brilliant little contraptions. Some have used, pulleys on exercise machines. Some have used pulleys, on their bedstand or whatever. I don't even begin to, comprehend how they would build something that actually works so well, but it actually in many ways works really well. And really then the problem just becomes keeping your head on the ground,
Right.
because this thing is, pulling with enough force to actually lift your head up off the ground a little bit. So if you can keep your head down then you just need to
Strap
have
your forehead to the bed.
have a little bit of
They'll put like weights on their forehead, weights on their chest.
Wow. How big of a class 3 do you think something like this could correct?
I mean, if our exercises of any value of reviewing my case, we could easily say now maybe 4 millimeter underbite
With no protraction device.
with no protraction to come edge to edge, and then maybe if you're additionally pulling a little bit, then you might get that little bit extra that you need to then be able to dentally put your bite together, right? Because whatever your actual skeletal underbite is, or you got to get the teeth edge to edge, and then assuming that you can't cheat with the teeth,
Dentally.
then you need a little more. You need a little more than what your underbite is to correct a class 3 into a class 1. So, I think that seems well within the possibility of like underbites of 3-4 millimeters. I think if someone expands sufficiently and, maybe uses something like this or some other, forward pulling mechanism, whether extraorally or intraorally.
And the FME has to come pre-built with the ability to attach to this sucker,
Yes,
right?
correct.
And does this have any dental effect at all?
No.
Not even right here? This isn't pulling on the backside
It's
of the last
supposed to
molar?
be clear of it.
It is.
Yeah.
By how much? How
Now,
much daylight
because
is there?
mine wasn't totally clear of it, that's why I couldn't really use it that reliably.
Because he was scanned to pre-expansion. By the time he had the availability to use it, his bite and his teeth shifted.
So what's the workflow look like for when you scan for this thing, when you receive it, when you start using it? Do you only start using it once you're done expanding?
I mean, I don't think we know that yet because we, to date, haven't necessarily received any tangible guidance on any of this kind of stuff from the company. But, I think they're waiting on, obviously, sort of our first couple people to report on their results and stuff like that, or experiences, whatever. But yes, the workflow goes like this. So basically, most people who come in knowing that they want to try to protract, I think the best time, let's say pending availability, when it becomes, more broadly available, would be just scanning for the expander and building the protraction wire at the time of delivery of the expander. That way you can expand and protract together.
From day one.
From day one. And then for those who might do it asynchronously, which means you might expand first, then we think the best protocol is to then rescan the maxilla, retake a CBCT scan, because those are actually used to try to align where this wire comes out, how this wire is moving, and the vector of pull in the midface to see if you can actually pull. Because if something changes about your device, well, you don't want to just conform to that and maybe just kind of pull like a little bit off kilter,
Right.
in one way or the other, especially because there's no play in this thing to be able to tailor your vector to what you want.
Mm-hmm.
It's just based on this protraction wire, which is the conduit between what's in your face and a point to pull outside of your face.
The female end that on the FME itself that attaches to these little male ends here, is that part of the anchor body, or is that part of the expander body?
Anchor.
Oh, so you can't add that later.
No.
That has to be determined.
That's the FMEP version with the tools in the back.
Okay, we call that FMEP when it comes with the female receiver for this.
Yes.
Mm.
Receiver is a good word.
Mm-hmm. Mm-hmm. And so this patient here, and we're going to blur him out completely to take away any identifying features, but is he patient 1 for FMA?
You could say that. I mean, in a way, I was patient 0, but I didn't really get to use it. I just got to try it out.
Is this the appliance you were wearing? This unit? Oh, no, you had your own.
Well, I had my own wire.
You had your own wire, but this
and I certainly hope I have my own unit, but but this unit, which attaches to the patient, this was, yes, we lent our body gear to him because I'm not going to be using it as much. This is a motivated patient with the time and the clinical need
and this was,
to do this.
To be fair, when we still haven't gotten any guidance on when more of these will be produced.
So there's
Correct.
only one in existence as far as we know that you have in your possession?
Well, at least that.
Well, the patient has it now in his
Yeah.
possession.
Let's
Let's
play this video and just see what we see. Oh, so he's demonstrating that you can move your head while wearing it. Oh, and you can go up and down.
Those white wheels.
Right. Is this patient a class 3?
Yes.
He looks a little bit, little sunken in midface.
Yep.
And now for the $1 million question. What's this thing cost?
We have not the slightest idea.
Really, that's scary, considering the way pricing is going with FME.
And from some of the guidance we've heard is that it's going to be just as much or more expensive than FME.
Am I to understand, and I'm hearing this from clients of mine, that the lab fee of FME is over $5,000?
The lab bill is very expensive, and it's close to that amount.
Right. So providing the FME is not necessarily, it's not that you guys mark up the FME because it's somehow exclusive or more labor. It's just that you pay a bigger lab fee, so you're passing that cost on to the patient. Is that right?
It's a significantly larger lab bill than the MARPE.
Right. To the tune of 3 to 4x. And this FMA is, I mean, just looking at it,
the lab bill, from what we are gathering, is going to be more than possibly the FME.
Okay. So there are lots of lab fees involved here, and that's the story with the cost thing of the FME.
Yeah.
How do you guys feel about that? And what kind of feedback have you been getting from patients about the costs of this treatment?
I mean, I'll speak first. I mean, the product is very, very, very well engineered. It works fantastic. We've clearly had great results so far. He has it in his mouth. It is, it's made of basically 100% titanium. So I think there is merit to why the lab bill is that high, but it is that high. And I think there's a lot of risk that comes along with this too, right? That a lot of our patients don't understand. And I think some of our colleagues and our providers do. That's why they may not be doing custom MARPEs or FMEs, right? Because there is a significant amount of risk, right? And the credit due to all of our colleagues that do this, we take a lot of risk, right? And it's something it's a real risk, right? It takes a lot of experience. It takes a lot of courage, right? Because you are changing somebody's anatomy from the outside, right? It's not like a nose job where you get a revision or something like that. This is some serious stuff. And that the magnitude of its importance must not be diminished, right?
Well, risk translates to my mind to insurance costs, right? The higher the risk of a profession, the greater the cost of it is to insure that, right? And so that's a real expense line on any profit and loss statement, is the cost that one pays for insurance. I mean, I know what I pay in insurance as a tax preparer and for JawHacks, speaking in public and media insurance and so on and so forth. Not to mention insurance that's paid on, a home or what. Insurance is expensive, and the cost of insurance continues to go nuts as, everything inflates in this economy. And insurance is something I did not appreciate how expensive it was until I started needing it.
I mean, that's definitely a factor.
Insurance sucks.
But
insurance does suck.
And I mean, also just to give another comparison touch point, right? So this hypoglossal nerve stimulation device called the Inspire, right? Inspire is something that is FDA cleared and is a insurance approved treatment for obstructive sleep apnea for CPAP intolerant individuals. So, and that involves a, sometimes 2-step surgery procedure to implant this thing in there. And it's, sure, it works well for some people, but it's also a little unpredictable. Sometimes one side of the tongue feels like it's being stimulated and the other doesn't.
Or it'll wake them up before they go to bed.
Yeah, exactly. So it's like, you have all these problems. Like this is like actually in many ways like a stupid ass treatment, right? Like that has nothing to do with the actual structure of the face.
Well, kind of what I call it. Yeah, well, I call CPAP the gold standard. MAD is silver standard, and this is more like a platinum standard. It's a really expensive Band-Aid, but that carries a lot of risk. You have to go through DICE procedure to see if you even qualify, and two, you have to go to general anesthesia for the surgery that implants this electrodes in your body. Then you get basically, it's like a Bluetooth activation, and then you can't adjust it yourself. You still have to go to the doctor. So if that's hyperactivating and you can't fall asleep, you have to go back to your doctor to adjust the settings.
Right.
And so where I was going with that point is, if insurance picks it up, then patients don't really think about what that costs or what the providers are paid for it or whatever. But if somebody's paying out of pocket, this thing costs about $30,000 to $40,000. Stupid ass, thing that works half the time. Right. That you're maybe even making a tongue more mobile inside a structure that's confined, right? It's maybe arguably not doing anything for people with certain anatomic restrictions.
Well, Mike Hutt said so much. He said patients that really need a jaw surgery often don't do well with Inspire because there's nowhere for the tongue to go.
Exactly. And that's, so, they're charging $30,000, $40,000 for this thing in the medical space. Now, I think perhaps our, friends who are, manufacturing and providing these, FME devices, I'm sure they have their own business dynamics and constraints or whatever, just so that they charge what they charge for a very excellently engineered product. So we're kind of picking up, a little bit of a premium lab cost for something that insurance has pretty much almost no chance of covering. And of course, we do have some patients with some exceptional circumstances where we can make a case on an individual basis. The patient might, be able to convince their insurance to reimburse
obviously,
them.
Insurance doesn't want to pay.
Insurance doesn't want to pay.
Yeah.
Insurance, right? Anyway, but like as orthodontists, we're tooth straighteners. We have treatments for straightening teeth, but then there's this other realm that came up on the profession so sort of quickly and recently that it's and is usually carried out for reasons that are functional in nature and not so much orthodontic in nature, although orthodontic indications do exist to do these types of treatments, and maybe doing them on, teens and young adults and stuff like that and kids is that's like orthodontics adjacent, but then orthognathics adjacent is like a lot of this other stuff. So we're kind of living in this world where we're like a little bit orthodontics adjacent for some applications, a little bit orthognathics adjacent. So how can you be adjacent to two things that are so divergent in their pricing model, right? You're talking about braces that might cost between $5,000-$10,000, and you're talking about orthognathics that cost between, maybe $30,000 and $100,000.
Yeah.
Right.
And also stuck in between the world of insurance coverage, no insurance coverage, health, dentistry.
Yeah. Like that's the whole point of this discussion. And it's not to I hate that we have to charge anything. I really honestly wish that America was a place where we didn't have to charge for this shit. I wish that this was an economy, we lived in a world and an economy and a healthcare system where this didn't have to be, because I do fundamentally, philosophically think that this is at odds with the interest of the general, wellness of the population. So fuck our healthcare system too. I mean, shit.
I mean, this is a great segue into what we're trying to do, right? Obviously I was exposed to this And the first time I saw it, I think we talked about it yesterday, was a patient that I was going to do Invisalign on. And thank God she didn't move forward because I was going to do retractive IPR on a class 3.
Many years ago.
Yeah, like 6-7 years ago. And the first time I saw the MSC2, she came back in for her cleaning and I'd never seen this contraption. So first thing I called him or messaged him like, dude, what is it?
Dr. Newaz was the provider of
Dr. Evans was.
Oh, Dr. Evans was the MSC type 2 provider that you just saw incidentally in this patient's mouth.
Well, she never came back to get her Invisalign.
Why was she in your office?
For normal dental visit.
Okay.
Yeah, and she's a regular patient. And thank God. So she got this. Dr. Evans is amazing. Worked very closely with her. And so, that's when I saw the MSC2, and then I hit him up and I'm like, bro, what is this? And he kind of went into details. And obviously after that, I started actually going to see with my patients 2 Dr. Evans appointments right before I started doing them. And then when we started working together, I saw the benefit of our patients. Forget the orthodontic component, the orthognathic that he just mentioned. You're changing these people's lives, right? Possibly avoiding jaw surgery. And when I started seeing the impact that it can have on the health of our society, that's when I'm like, I was all chips in, right? And now our goal is, how do we make this as a possible first line treatment for UARS or OSA? And that's where we're starting to do our clinical research study, where we can actually see the before after of a sleep apnea test, blood pressure, blood sugar, and things like that. So the more validation we get in the medical community, our goal is to bring this from an orthodontic to a medical orthognathic procedure, where if you go to your sleep physician, they don't just look at your sleep apnea test, they look at your actual jaw. They look at the apparatus, your nose and your mouth, that the air comes through, right, to bring oxygen into your body. And for a lot of patients, if you look at where those obstructions are and you literally take a step back and solve them, you could solve sleep apnea and UARS for a big portion of patients. And that's not the way the medical industry and the medical realm looks at it right now. So the more research and the more validation we get, right, then the medical community is more apt to believe in this and see this, right? The CBCTs don't lie.
And then the more likely that these procedures get insurance coverage. Because really, I mean,
And that's our goal, right? Our goal is, and then that's obviously treating adults and things like that. And then Dr. Nawaz's passion is interceptive. So how do we actually bring these concepts to educate parents so that their kids don't need to have this as adults, they get treated as children.
Yeah.
To prevent all this FME, MARPE discussion.
Yeah.
Right? With proper, tongue habits and pacifiers and feeding and hard chewing, et cetera, et cetera.
Well, I appreciate the discussion, guys. I mean, I know as someone who individually is priced out of a treatment that I want, namely like a jaw surgery, that if I could really afford it comfortably and could afford to deal with potential complications that might arise, I would probably do it. But it's cost prohibitive. So I know what it feels like to feel like I have a medical need to do something that would allow me to live a better, happier life, but dollars are creating a boundary and preventing me from doing that. I get the frustration. I appreciate what you guys do for people that can't afford treatment. You guys put out a ton of free content and a ton of free information that at least allows people to have a seed planted and to avoid the wrong treatments, right? To avoid paying for treatments that might be less expensive, but that actually might take them backwards in some sense. So maybe if they can't afford it now, they can at least have knowledge now at low or no cost, and then try to arrange their lives to be able to cash flow for a treatment in the future. And
hopefully, this is our ikigai. This is our life purpose. And when people ask us, why do you travel so much, or why do you work so much, or how do you do this? This is our life passion. We want to help the world breathe better, right? So, you could call this work, but this is what our lives revolve around. We want to help humanity, and our goal is to make this more prevalent, and hopefully our goal is for this to be covered. So if you wait long enough, knock on wood, it should be a medically covered insurance procedure at some point.
Yeah. The more I think about it, the more I do feel like it is just a technicality of the way that our healthcare system is structured, with this odd distinction between between medicine and dentistry.
Yeah.
I mean, they're even stratified in terms of the schooling and in terms of the licensing and the degree. But it's like, why is the mouth somehow separate from the rest of the body when it comes to health in this official way? It's totally arbitrary, really. I mean, it's a historical thing, really. But it's creating real problems, real financial challenges for young people that are sick, that want to be able to do something about it, but that can't because they're basically priced out. So I guess,
and we hate that. Again, it makes us super uncomfortable that this is a discussion. Again, I like no part of this discussion. This is just difficult to navigate because, of course, we have to, invest in resources and personnel to service the patients. These patients need more, in terms of time and in terms of support, in terms of collaboration and tracking and, coordination with other providers. I mean, it's a lot of work, I think, that people don't necessarily see. And honestly, 95% of our patients are super appreciative and understand that, and all of that, right? You'll have a few that, perhaps don't, necessarily appreciate that. But, for the most part, I mean, we have very good, people know that we're out here to really just try to find people a solution within what we can provide, and we're here to try within our means to help people have access to these treatments. And we just encourage people to just at least come talk to us, come ask, get the information. We roll from there. We do a lot of creative stuff, just like we do creative stuff on the clinical side. Like, we do creative stuff there too. We like to sort of contemplate ways to get this done for people. But I think, it's going to take, just for fun, I sometimes do kind of look at, maybe an open academic position here or there or something. Like, maybe there's going to come a time that, it makes sense for me economically to block out a little bit of time for a little bit of engagement with a, academic position where we can maybe, teach this stuff on a, at least a little bit more foundational level, right? Getting more providers in tune with this work, making this work a little bit more commonplace, being able to research it, have access to, research and, funding resources.
Yeah, so any of your listeners or, have those resources that can help us kind of get this more mainstream to the medical community, we're all ears, because that's what we're going to need, all of us in on this together to try to make this more accessible to everybody and to the whole world. Because, basically the people on your podcast, Reddit, Discord that know about it, most other people don't know about this option as a solution to their problems.
So you guys said patients should contact you. Last subject I want to discuss today: should patients who have had jaw surgery but now want a MARPE, any kind of skeletal expander, custom MARPE, FME, et cetera, should they contact you? Let's talk about MARPE after jaw surgery very briefly, probably since we've been talking now for several hours. Can you guys give me maybe give me the short version of that, and then maybe we do like a medium length version of that discussion around how much success you've had with that? Does FME make that process any easier as compared to custom MARPE, or is it the same challenges? What are those challenges? How feasible is it for someone to get a complication-free skeletal expansion post, one jaw or one piece or multi-piece maxilla
Great question. So I think, I mean, just quickly on the MARPE FME thing, just so we don't get too into the weeds about that, the actual practical considerations for that are very minimal. Like, what is more a consideration is the actual status of the maxilla and the continuity of the bone boundaries and the firmness and the union and the positioning of the plates. Exactly. All of that stuff, those are the considerations more so than what appliance you're using. We've done both, MARPEs and FMEs. Of course, for some of the people seeking FME in particular, we're doing FMEs. For others, we're seeing if MARPE or FME makes more sense. But usually, but as far as like, does one categorically make more sense than the other? In a post-surgery patient, there's no real discussion around that. I think it's more, those are the things that we're looking at, right? To see if, and then also to anticipate where the expansion occurs, right? When you've had a LeFort 1, you've kind of have like a little silent fault line, somewhere in the midface. Sometimes we have a little step on the outer surface of the bone, but it's all continuous. It's all pretty rigid. Sometimes we have some defects in the lateral wall of the maxillary sinus and stuff like that, which is, again, customary and not of really any clinical concern in the absence of symptoms, but it could be a consideration for behavior of an expander after surgery. And sometimes the location of the pterygomaxillary fracture or disjunction is a little bit different on one side or another side. That's sometimes something to look at. And we have, some cases where, like, we have one case in particular that was a very successful expansion of a 33-year-old female with a prior LeFort 1. But we did see a little bit of that right favored, kind of yaw movement because of the way the pterygomaxillary junction behaved, on expansion, because it just, it basically gave out a little bit more. And you could see that it was, a prior surgical thing that made it possible for that to happen. But
the union
overall,
there on that one side was not as strong as the union on the other side. So due to the phrase you used earlier that MARPE skeletal expanders are this battle with Newtonian mechanics, you have, less resistance on one side, that side is going to go. And so surgery introduces more of that.
More variable. Yeah, more variable.
Basically, if a person has already had jaw surgery, you're looking at a much higher risk, right? Much more variables to account for, more possible complications, right? And so that's why we recommend getting a consultation with us first before jaw surgery. And if like the case is impossible, then you need to understand that there are a lot of risks, a lot of variables that need to be accounted for if we're going to do expansion.
Yeah.
And should you need expansion later, right? After, if you elect to do jaw surgery, and then should you need expansion later, it's good to let people know that you might have some challenges with expanding, at least in this sort of real nice, wholesome way that we like to expand the upper midface and all that. We tell a lot of people with prior surgery that obviously that's what's less predictable. Right? Are we going to get this upper midfacial zygo type of expansion? It's really hard to say. Again, our data shows very mixed results in that regard. We have some that do great and everything comes, apart and does so really well. And, nasal volume increases pretty reliably. But, just how the upper midface behaves and all this kind of stuff just depends on, how firm those bone segments all are.
Because sometimes the bone segments don't heal the way the surgeon anticipates.
Right.
Right. And so if you're adding force, you're adding possible risk.
Force. So when a post-surgery patient comes in and you scan them up for a potential skeletal expansion, what do you look for? Let's start with plates. Like what kind of plating contraindicates MARPE?
Across the midline.
So like an Alfie across the midline plate, that singular custom plate that goes all the way, that'll just prevent the maxilla from spreading, right?
And I've had a couple cases where just that centerpiece was either cut off, with a separate surgery, or that the plate in entirety could be removed. Usually you need the surgery to have happened a sufficient amount of time in the past with really good healing and with really good sort of surface analysis of the bone to ensure sufficient continuity to tolerate expansion. Obviously, in surgery cases too, we tend to go a bit slower and a bit more conservative.
And another, we're talking about like double jaw, but even a dome procedure, right?
Oh yeah, sure.
Because there's still cuts over there, and sometimes the bone does not heal according to plan, right? And I've seen that the past couple weeks too, right? So you have to be cognizant that even, a dome or SARPE can cause issues as well.
Yeah, any pre-cutting of the maxilla, it sounds like, can predispose to a kind of...
And those are all just risks. Once again, you need to understand that all of these things have inherent risks with them. Procedures.
Yeah, and even plate removal to stage you for a MARPE after a jaw surgery, that's a big procedure in and of itself. Because you got to completely open it back up.
Yep.
Right? That's general anesthesia. Probably expensive. So yeah, there's definitely a lot to consider, but it is possible. Yeah. Well, guys, I appreciate the time today. It's been amazing sitting with you. It's been a hell of a podcast. We covered a lot. And thanks for having me down in Florida. It's been a lot of fun. And for all of the patient advocacy that you guys do, all of the awesome content you put out on your YouTube channel, where can people find you guys?
Airway Ortho on YouTube, our Instagrams.
What are your Instagrams?
Dr. Jaffari DDS and
Dr. Newaz with 3 Z's.
All right. And I'll drop those links in the description. But thanks again, guys.
Thank you for coming. Yeah, we really appreciate you taking the time for on Labor Day weekend, spending time with our family, away from your family.
No, my pleasure. My pleasure.
Oh, yeah.
So we should do this again.
Well, at this rate,
should.
next year.
Yeah.
We did one last July. We did one this August.
Yep.
And so next summer.
Next summer.
We'll get the update on maybe FME 5.5.
Oh, whoa.
Yeah. But thank you.
All right, guys. Thank you.
Thank you.